Good morning, everyone. Thank you for waking up early on Sunday for this motility course. I'm Prakash Gwali, and I'm going to moderate the course. Reena Yadlapati and Josh Sloan were the organizers of this course, but they couldn't be here today because of travel restrictions. So we'll work around that. This is going to be a combination of live talks and Zoom talks, again because of travel restrictions. And we have time set aside throughout the course for interaction, Q&A. And there are plenty of experts in the room, so we can have any kind of question answered. We also have a couple of industry representatives, and they will be outside at their tables. Unfortunately, they don't have equipment because I think most of the hardware has already been sent away after the meeting. So without further ado, let's start with the first talk. Dr. Zubair Malik from Temple in Pennsylvania is going to give the first talk. This is all going to be patient-based, symptom-based, case-based management. He's going to talk about achalasia with a focus on type 3 achalasia. Zubair.
Thank you. Good morning, everybody. Thank you for coming out on the last day, and thank you to the AFS for organizing such a wonderful conference. It's wonderful to be in a room with GIs and surgeons who are all like-minded and willing to have nice conversations about things. So it's been a really fun weekend for me, and it's an honor to be here on stage and to present to people that are sitting here like Dr. Gaiwala and everybody else who you learn so much from over the years and try and hopefully live up to their standards. So let's go ahead and start. That's me. I have no disclosures. All right, so let's start with our case. So I have a gentleman, B.A., he's a 68-year-old Caucasian male who came for the evaluation of dysphagia and vomiting. And B.A. came to us all the way from Florida, and we don't know any good GIs down in Florida who do motility, right? Dr. Richter is one of my mentors, and he trained me, so no, but for whatever reason, he got sent up to us at Temple. So he told us his symptoms started 20 years ago. Dysphagia started with cold liquids only, and then eventually worked its way up to solids, and now it's kind of almost every meal. Whenever he eats, he starts eating, things go down okay for a little bit, and then all of a sudden he feels like things are stuck high up in his neck and his chest. And then after that, he starts vomiting. What he says is vomiting. Everything comes up. And it's almost every single meal that this is happening for him now. When he does what he says vomit, it looks like just chewed up food. It's not digested food, it's just what he chewed up and was taking down. Like I said, it feels high up in his neck. But when he does feel this, sometimes he gets up and tries to stretch his back or walk around a little to see if it'll make it move. And if not, then he has to go and vomit. Other than the times when he has this feeling of things getting stuck, he doesn't have any nausea or vomiting. He doesn't have any early satiety or bloating or any other symptoms that are typical for gastroparesis either. Over the course of 20 years, he tells me now he hasn't been losing any weight. Caveat to that, he doesn't really gain weight either. Sometimes he loses a little weight over the years if he's tried, but he hasn't really been able to gain weight. Not that he wants to, but he just can't. And he's seen several GI doctors over the course of time, Florida and in other states, without really much any symptom improvement. So obviously he came with a stack of records. We try and sort through them. So he's had multiple EGDs over the course of time, from the early 2000s all the way till 2018 or so. One of those EGDs notes in the report esophageal spasm in the distal esophagus. The rest of them, nothing really. They took biopsies multiple times of the esophagus, never showing any EOE or any other disorders there. They've done dilations, both savory and TTS, balloon dilations. Both of them had gone up to 20 millimeters at times. He said, maybe I had a little bit of improvement with those, but not really, and it was very short-lasting if I did have any improvement at all. Eventually, somebody said, let's get a gastric emptying scan, make sure this is not gastroparesis, and that was normal. He had CT scans, he had x-rays, but in all his records, I couldn't find a barium esophagram, and he couldn't remember doing one as far as he could recall. All right, so since he flew, he also had an manometry done at an outside institute back in 2010. All that I got is a little paper note of this, no pictures, no images, nothing like that. But this is what was written on there. LES pressure 13.9, IRP 10.7, 90% peristaltic swallows, 10% simultaneous. And that was his distal amplitude of 81, all right? So not sure what that means. Like I said, couldn't see pictures, couldn't see how that was set up to read, but it was there. All right. So, since he came from far away, he was going to spend a few days with us. We had kind of set this up based on his initial things. He was going to get a manometry. He was going to get an EGD with FLIP, as well as Bravo off PPI. And he was going to get an esophagram. All right, so the order is a little wonky because it was just set up as kind of a quick visit here. All right, so this is what his esophagram pictures look like. And that was the read we got back from it. So you can see, we had some beautiful talks during this course about looking at esophagams. Dr. Richter, Dr. Lippum, they showed us beautiful pictures, much better than I can do, some beautiful videos. But you can see here, the read came back moderate dysmotility, delayed emptying into the stomach. You can maybe make something out there at the GE junction. You can maybe see some spastic stuff in the distal esophagus, but not totally clear, but particularly for an untrained eye. But if you start looking at a lot of these, you could probably pick some things out. Let's continue. So he also had an EGD was going to be a Bravo, so we did the EGD, and we go down, and what we thought was he had kind of a corkscrew-looking appearance. It was tortuous. It was almost spastic looking in there. But the LES was hypertonic, and when we pushed through, you could kind of feel that resistance, that little bit of a pop. The Z-line was maybe irregular, but who knows about that? That's a whole different discussion. And on retroflexion, the G junction looked normal. But when you look at those pictures, I'm sure most of you noticed that that's not that's not loose. That's really snug around that scope, right? It doesn't look like your Hill grades 2 or 3 or a hernia. It looks pretty snug around the scope. We did deploy the Bravo, and it came back as 0% acid exposure. What was interesting is we did a flip at the same time as well, and this is the picture we got. This was at 60 mil balloon distension. You could see that LES looks really tight. You see some retrograde contractions there. And again, we've had wonderful talks on EndoFlip, so I'm not going to spend a lot of time describing this or describing EndoFlip to you, but you can see what this looks like here. All right, so finally we get our manometry, and this is what our manometry looks like. As you've heard at this here based on Chicago 4, sometimes a type 2 can be a type 3, right? So it's important to kind of look at more than one swallow. And if you were just to pull aside that first swallow there on your left, maybe you would think this is achalasia type 2. But if you start digging in a little deeper, you start looking at some of those other pictures, even though they could look almost simultaneous, you see that high pressure distally, right? And this is something that's really stood out in Chicago 4 is being able to differentiate that some of those, what you would have previously called type 2, actually have that strong distal component, and it may actually be a type 3 that's hidden in that simultaneous contraction. So just to go off on a little rant, this is the reason it's important for a trained eye to look at a manometry and not just use the computer result, not use somebody that doesn't really look at these, right? If you don't look at this, and for example, I didn't show it here, but if you have some esophageal shortening, what happens to your IRP? If you're not paying attention to that and somebody else looks at for you, your IRP somehow goes to normal, right? Because that shortening pulls up that LES. You don't see what's actually LES relaxation. You show a gastric pressure that's much lower. You get a normal IRP. What happens if somebody looks at this and And back in 2010, when we were still using the CFV, right, contractile front velocity, and you line it up and it looks like it's peristaltic. It doesn't look maybe rapid. And so instead of calling this aperistaltic, you call this a peristaltic wave. What happens to that patient? A patient that has achalasia is now diagnosed with something that's not achalasia. They're diagnosed as normal. And so it's really, really important to actually look at these studies yourself. Make sure that whoever's looking at it is somebody trained in manometry and that they spend time to look at these things and make sure it's marked properly. Sorry, I'll get off my soapbox now. And so our diagnosis, achalasia type 3. There's his IRP of 20. There's a DCI. His distal latency was short, all right? So fantastic. We made the diagnosis. So let's talk about a little bit of what we can do. We've seen some of the diagnostic things here. So what's the data? What can we do? Well, obviously, when you start with these things, you talk about medications. What medications can you use? We know medications are not great for achalasia. They don't work very well. You have to time it really well with meals and hope that it works, hope nothing gets stuck. And it's really, really reserved for those patients that are so ill, probably from other comorbidities, that you can't even do an endoscopy on them. And that, most of us that do endoscopy know that that's like a really, really sick patient. Most people can tolerate some form of endoscopy. So if you can't do that, you can try your calcium channel blockers, your nitrates. But if not, then we can try some of these other things. Oh, sorry, just a quick refresh before we go forward. I know everybody in this room knows this, your types of achalasia, 1, 2, and 3. And I'm not going to spend time on this. We've seen lots of this here. All right, so what do we start with? Well, there's Botox, right? Botox can work. And Dr. Pashrika back in 1995 published this article in the New England Journal looking at Botox in patients with achalasia. And you can see there the symptom scores improved significantly in those that received Botox versus those that didn't. Also of note, they showed compared to placebo, the LES pressure is reduced. The retention at 5 minutes on a time barium esophagram is improved compared to placebo. And then they followed this out beyond a week to 6 months, and you could see it was still improved, although you can see it's starting to creep back up, right? And we know Botox is a very temporary treatment. There were all those studies previously that said that Heller myotomy becomes more difficult after Botox, maybe because of scarring. I think a lot of the surgeons in the room will tell you now that they've done lots of cases that have had Botox previously, and they feel just as comfortable doing that as doing native, no previous interventions, right? So how much this affects something, I'll leave for our surgical colleagues to tell us, but anecdotally, I could tell you that everyone that I've spoken to says, "Go, I'll still do whatever, no problem," right? So the problem with this is it's old, right? There was no achalasia types yet. But if you look at more data that came out later, if you look at typing of achalasia and how they respond to Botox, type 3 did not respond as well compared to type 1 and 2. Makes sense, right? Most of those studies looked at Botox to the LES, so didn't respond as well. Now, Dr. Tak and his group looked at Botox to the body of the esophagus for DES, and they had good results with that. So should we be doing body and LES for these patients with achalasia type 3? That's something else to be discussed. All right, so if not that, then you talk about your more definitive therapies, right? You have your pneumatic and your laparoscopic Heller. And this was the landmark study in 2011 comparing the two. And if you look at the data here, everything, they said there's no difference between the pneumatic and the Heller group, right? If you look at out to 2 years, there's not really much difference. It's more patient discussion. Now, we all know there's some caveats to this study. The pneumatic group could be re-intervened. The Heller group couldn't. Would that have made a difference if you could just touch up, somebody that had a Heller? Sometimes you go in, you do a quick TTS, and they feel great again for whatever reason. Maybe there's a little scar tissue. So, yes, there's caveats, but the success rates were good for both. We're not talking like 60s or 70s. We're talking about high success rates for both these groups. So, yeah, both of them work. But if you look through this data, what's one thing that you're missing here? You're missing the types of achalasia, right? And why is that? Because this study was performed from 2003 to 2008 When did Chicago classification start? 2008. So they didn't have Chicago classification back then. So you don't have that data here, but the same group went back and published some results at 5-year follow-up and published this in 2016, same patient population, and now they could do a post hoc analysis of the subtypes. And they had, again, they showed that 5 years out, they had good success, 84 versus 82. There was no statistical significant difference there. But you can see the 25% of the PD group required redilation, whereas, again, we said the laparoscopic Heller group couldn't have anything done. Your perforation rate was 5%. But when you look at the data here, now you can see the types of achalasia, right? So you have your type 1 that did overall about the same. Your type 2, for whatever reason, they showed pneumatic was better than Heller. Again, other studies don't say that they're much different between the two, but both very high success rates. But then look at your type 3. Your success rate goes down significantly. And the laparoscopic Heller for this group seems a little bit high. When you look at other studies, it's not nearly that high. But your PD group is down to 48%. All right? So there's been other studies that came out along the way. This surgical group looked at predictors of outcome in surgical treatment for achalasia. And they tried to find what's going to predict a good outcome. And one of the things they saw, and this is, again, back in 2010, so right shortly after Chicago classification came out, that type 3 had the worst response to surgery, right? So 30% failure rate in this group, whereas type 1 and type 2, not as much. They had better success rates. All right, so then came the poem, right? And this was what a lot of people were touting as a savior for achalasia. And Dr. Stavropoulos did a wonderful job of talking about poem and where it's going and where the tunnel is leading us to, so I'm not going to spend time on that. But let's look at some of the data that they found for this. The first thing is, not the first thing, but Dr. Kashab from Hopkins had this multi-center experience where they looked at poem for these spastic disorders, DES, jackhammer in particular for us, type 3 achalasia. And now you're looking at 96% success rate, right, down here. So you can see that our success rates got much better when we started talking about the poem for these spastic things. And it's obviously because you can cut that longer segment. So the long-term outcomes, here's another study recently in 2021 that just came out, looking at 5-year follow-up of these poem patients for type 3 achalasia and DES, and you have good success rates maintained out to 5 years. The numbers are not huge, but we know achalasia type 3 numbers are not big for anything that we found unless you start pooling stuff. So 13 out of 14 patients had success at 5 years. That's great. And when you look at DES and jackhammer, similar numbers. So good success rate and maintenance of reduction of the Eckerd score. All right, so is poem the answer for this? Well, they did this systemic review and meta-analysis, and they showed that there's high success rate, low adverse events rate. So achalasia, or poem is our savior for achalasia, right? And that's across the board they started showing this. You have very good success rates. And then the important part here is you look at things being tailored, right, to the right length. You have to look at tailoring. This group looked at tailored versus non-tailored, and they found that tailored myotomy works better. How do you tailor it? Well, Dr. Richter's group had this study that came out recently, and there's a discordance between your high-res manometry, your EGD findings, and your esophagram. So it's important to kind of not just look at one study, look at all your studies. Find out the length of this spastic thing, and if you're going to err on the side of a little long. Dr. Richter's group in this paper, which I don't have here with me, but they showed nice pictures where they have a non-tailored myotomy, and when they brought the patient back in that still had symptoms, they did another manometry, and their upper segment of their esophagus was still a bit spastic. They went back and cut that again. Patient improved significantly. So make sure you look at all your data before you do this poem, all right? Now, what's the drawback of poem here? So to play devil's advocate, and I love poem, but there's a big drawback, and that's the reflux. And Dr. Richter always says he's really worried about this, and Dr. Katz as well. They're worried about the long-term reflux. Well, this group recently published this study, and on the right you see a few studies looking at their reflux data. Symptomatic reflux, 20, 25, 30%, but esophagitis goes up 25, 30%, and when you have a positive pH studies, they showed anywhere from 30 to 50% of patients have positive pH studies. Now, one study had 13%. That seems a little abnormal here, but most of them are closer to that 50%, right? So if you have such a high reflux rate, and these guys also said how many of them respond to PPIs, and you look on the left, and they said 80% of patients that had POEM that have reflux respond to PPIs. That's great, except if you do the math, and I probably have to take off my shoes to do this math, but when you do the math, that means 10% of patients that are getting this roughly are not responding to PPIs that have reflux. That's a lot of patients. And yeah, 5 years out, you probably aren't going to see anything. But what's going to happen 15, 20 years down the road? That's a question that we don't have answers to yet. So it's going to be important to follow these patients. All right, so quickly we'll get back to BA. BA came and had a POEM with us, and he had a 16-centimeter myotomy, and you can see from left to right his pre versus post POEM manometry, and that spastic segment is gone. The LES looks significantly improved. He's now 2 years post-POEM and doing great. Very rare symptoms of dysphagia. Eckerd score went from 6 to 1. He did have some GERD symptoms, so we put him on a PPI, and he feels great on that. He had an EGD just a couple months ago. No Barrett's, no esophagitis, looks great. And he's extremely happy. He gained 8 pounds. So, just to conclude, I mean, achalasia is very treatable. We all know this. That's why we're here. But diagnosis is often missed or delayed, and achalasia type 3 was a little bit harder to treat. Botox can be extremely helpful for these patients, but results, again, type 3, not as good. Now, sometimes if you maybe try this DES protocol, you could get some improvement. Pneumatic inhaler are equivalent in terms of treatment, but not as successful in type 3, and that's really where our POEM comes into play. Type 3 success is great with POEM. You got to do this long tailored myotomy, but patients have really, really good success, and they do really well when they didn't do as well with pneumatic or Heller. It's just really important, as other people have said, and Dr. Pandolfino mentioned, he follows these patients himself. He brings them back every few years and does an endoscopy, and it's important for us to not just do a POEM and say, hey, you're cured of achalasia, go back to wherever you were. No, we have to make sure that they don't develop any of these long-term consequences. Thank you to everybody in AFS for having me here. It's been a pleasure.
Thank you, Dr. Malik, and we'll have a brief Q&A after the next talk, so if you have any questions, just hang on to them. At this point, I'd like to welcome on stage Dr. Rita Knotts. She's from NYU Langone. She's an assistant professor of medicine, and she's going to tackle this conundrum of EGJ outflow obstruction. So, Rita.
Good morning, everyone. Thank you for the AFS for a wonderful conference and for having me here today. And thank you guys for hanging out with us here until the very end. So I hope I can do this justice, but today I'm going to talk about EGJ outflow obstruction, our current diagnostic tools, and how we're going to manage these patients. So let's start off with a case, and this is a real case to our practice. It's a 53-year-old woman with a history of depression and chronic back pain who presents with complaints of episodes of epigastric and chest pain about 10 times a day, usually while eating or shortly after. Sometimes she feels like something stuck in her chest, and over the course of 4 years, and again, I think I can reiterate Dr. Malik's sentiments, maybe about 1,000 pages of medical records later, she's had four previous evaluations with 4 GIs. PIs, and has undergone an extensive evaluation with 2 upper endoscopies, one of them with a Bravo. She's had a wireless motility capsule, SIBO breath testing, a CT chest, enterography, and abdominal ultrasound. Ultimately, her CTs and her ultrasound were only remarkable for hepatic steatosis. Her motility capsule was normal. Her endoscopy only showed mild gastritis with normal esophageal pathology, and her Bravo had a normal total esophageal acid exposure with a Demeester score of 1.9. Her current medications include Nexium, bupropion, trazodone, gabapentin, and morphine. So not surprisingly, because we're talking about EGJ outflow obstruction, we did a manometry next. But actually, this case highlights several important factors, which we're going to go into, but her history of pain and ultimately the use of opiates, which we commonly see in EGJ outflow obstruction patients, the extensive evaluation here for what seem like obstructive features that include a negative Bravo, meanwhile the patient's still on PPI, and all her prior imaging studies, which have all been negative. So this is actually an example of the patient's supine swallows, and we can see here that she had consistently elevated median IRP with evidence of intrabolus pressurization, and we're going to get into the heart of this within the next few minutes. But this past year has been certainly interesting for us, and not because of COVID-19, but actually my colleague Abe Kahn likes to call this past year the golden age or year for esophageal motility, because so much has been published and become increasingly recognized. And up until this time, we were using the Chicago classification version 3, which really defined EGJ outflow obstruction as having an elevated median IRP of greater than 15 in the absence of achalasia. But ultimately, this meant that all of these patients had EGJ outflow obstruction, and this was often overdiagnosed and led to an array of treatment attempts that often were not necessary. So it's really important to understand whether or not your patient actually has true obstructive physiology and that's causing their symptoms, and that an elevated IRP isn't necessarily EGJ outflow obstruction. And so now, using the Chicago 4 classification, we've become a little bit more stringent. We've heard this a lot over the past few days, but a manometric diagnosis of EGJ outflow obstruction is always considered clinically inconclusive. And a clinically relevant and conclusive diagnosis of EGJ outflow obstruction requires several factors, and we're going to discuss each one of these. A manometric diagnosis of EGJ outflow obstruction, which includes the utilization of provocative maneuvers and positional changes, clinically relevant symptoms, and other supportive data that include either an endoflip or a timed barium esophagram. So let's start in the office when they see you with the history. What are your patient's symptoms and why are they having this study done? In our patient, she was having chest pain immediately during the meal or immediately after, but we really see dysphagia and non-cardiac chest pain in a lot of these patients. And in the age where we're doing a lot of open access manometry now, especially in the setting prior to anti-reflux surgery, we should really approach this diagnosis of EGJ outflow obstruction in patients with reflux with caution, and it may just be incidental. This may not reflect true obstructive physiology. It's important to take note of medications and antipsychotics that they're on, any surgical history, if they ever had a bariatric surgery which could be contributing to their obstructive symptoms. Do they have any underlying conditions, malignancy, EOE, or amyloid that could be contributing to this? So actually in this study examining chronic opiate users, looking at those who used opiates during the time of manometry and those who were off for 24 hours, EGJ outflow obstruction was present in almost 30% of these patients. And there was also an increased prevalence of type 3 achalasia in these patients as well who were on opiates. So auditing your patient's medications is critical because it really could be the cause of your patient's symptoms. And now piggybacking on this, we really should understand the heterogeneous nature of EGJ outflow obstruction. It could be a result of several causes. Again, you can have secondary causes, including medications, your structural causes, malignancy, and infiltrative causes. But maybe this is an achalasia variant, and maybe we're seeing this patient sometime in the evolution of their disease. And so this is a different case, but this is a patient that actually presented to one of my colleagues a few years ago with complaints of dysphagia. And we can see here that, she was diagnosed with a manometric diagnosis of EGJ outflow obstruction, but there was ultimately an elevated IRP and some evidence of intrabolus pressurization. But then she was lost to follow-up, and she presented to us actually again last week where we did her manometry. And this is her manometric pattern now. She was still having consistent symptoms of dysphagia, but now she has what looks like a type 3 pattern. So maybe we're seeing these patients with EGJ outflow obstruction sometime in the spectrum, and we really need to think about what the future is with them. So now let's move on to manometry. Now, a lot of my references are going to be using the Medtronic software. So in order to make a diagnosis of EGJ outflow obstruction, of course, you need an elevated median IRP of greater than 15, but you need to also have more than that. You need to have more than 20% of swallows with an elevated intrabolus pressure. And that's this area right here that precedes the contractile front, presumably upstream of an obstruction. So it's this intrabolus pressure that needs to overcome the EGJ residual pressure to cross the EGJ. And when it's increased, it could indicate that there's some obstruction to passage and transit along the EGJ. And we use a threshold here of greater than 20 millimeters of mercury using the isobaric contour tool. Now that's just found by clicking on the isobaric contour tool and moving your marker to the 20 millimeter of mercury marking. And everything that's outlined should be 20 millimeters of mercury and above and beyond. And so there was also a tool that actually was able to calculate intrabolus pressurization using the older versions of the Medtronic software, but that was phased out in versions 3.0 and beyond. And we also need to also need these findings in the upright position as well. And when we think about IRP, you really gotta, I think we've heard a lot about this over the past few days, but you need to consider the factors that influence it. So that's not just the intrinsic lower esophageal sphincter, it's the extrinsic factors like vascular artifact that can also cause this elevation. And we can see a resolution of this in the upright position. So an IRP of greater than 12 in the upright position has a pretty good sensitivity for identifying both radiographic evidence of EGJ outflow obstruction as well as symptomatic dysphagia. And this is our patient's upright swallows. We can see here there is a consistently elevated IRP. The median elevated IRP was actually in the 30s, and there's increase in intrabolus pressurization that's all throughout. And this really supports our manometric diagnosis of EGJ outflow obstruction. But we really need to understand pressurization patterns when we're thinking about outflow obstruction, because it's not just a number, it's a pattern. And pressurization that's seen on manometry typically indicates that there's some sort of compartmentalization of pressure on a manometry. And multiple patterns here can be relevant. This first patient is a patient who had a lap band. And here we can see a band of compartmentalized pressure between the lower esophageal sphincter and the lap band distally, indicating that there may be some sort of compressive effect here. And evidence of pressurization. Now, the second patient has a hypercontractile swallow with a band of pressurization that's immediately preceding it, also indicating that there may be some sort of obstruction to passage here. And of course, this third patient is a type 2 achalasia pattern where we're seeing pressurization and compartmentalization of pressure all the way up to the upper esophageal sphincter, indicating that there's obstruction to passage here. And these pressure patterns become further evident on further evaluation with provocative maneuvers that we're going to use to help us diagnose EGJ outflow obstruction. So the first, again, we've heard about this before, but is a rapid drink challenge, a 200 cc water bolus given to a patient with a straw in the upright position and ask them to ingest it as quickly as possible. Now, this is a high volume, high speed stress test to LES opening and may be able to provide more clinical relevance. And here what we're seeing, or we want to see in an intact rapid drink challenge, is complete relaxation of the EGJ and absence of esophageal body contractility during the deglutative inhibition period. Now, you may also get an augmented after contraction, but that's not entirely necessary. And the pressure here is higher if there's an obstruction at the EGJ. So here's the rapid drink challenge for our patient. And when we have an outflow obstruction, we're able to see evidence of pressurization in response to this volume loading. And we can see that in the patient that we're discussing. We can see that there's panesophageal pressurization throughout, and there's also an elevated IRP. But ultimately, you need an IRP of greater than 12 and this presence of panesophageal pressurization to further support your diagnosis of EGJ outflow obstruction. And that's also been shown to be predictive of outflow obstruction on time, esophagram, as well as symptom severity. And you can also see esophageal shortening with this pressurization pattern that can also make you consider whether or not you have a patient with achalasia or EGJ outflow obstruction. Now let's move on to our multiple rapid swallows. Now, we typically think of this as a diagnostic tool to assess for contractile reserve. But similar to the rapid drinks challenge, the rapid swallows of the multiple rapid swallows allow you to assess if there's intact inhibitory innervation to the lower esophageal sphincter. So here's an example, the first on top, of a normal pattern. You can see a lower IRP during the multiple rapid swallows as well as during the rapid drink swallows with what looks like deglutative inhibition all throughout. You're not really seeing any contractility during this period. And this correlates well to the barium esophagram all the way on the right, which shows the barium flowing freely and no tablet retention. But in the setting of outflow obstruction, you can have this pattern of pressurization or panesophageal pressurization. And similarly, you need an increased IRP of greater than 12, and that's been associated with radiographic evidence of outflow obstruction. And we can see here that it's also correlated with barium retention in this outflow obstruction patient. Now, this is our patient's multiple rapid swallow sequence, where you can see very little relaxation of the lower esophageal sphincter, as well as a pressurization pattern where we're supposed to be seeing deglutative inhibition. Now, aside from provocative maneuvers, you can consider the addition of a solid test meal to your study, which can increase the yield of major motility disorders. And in this study examining 220 patients, they found that the solid test meal actually helped them to identify those patients with EGJ outflow obstruction, especially those who had normal patterns on wet swallows. So in this setting, you can provide a standardized test meal, or you can ask the patient to bring in a culprit meal. And an IRP of greater than 25 millimeters of mercury is what's considered the upper limit of normal here, and you really don't want to give them more than 8 minutes to complete this meal because that's what's considered abnormal. And you want to make sure that you document symptoms as well, because symptom correlation here can provide confirmatory evidence of EGJ outflow obstruction. And when you really think about this, a lot of our patients are complaining of solid food dysphagia, not dysphagia to little bits of water. They're complaining of solid food dysphagia. And so this can really, the addition of solid swallows can really help you get a better sense of their physiology while they're actually eating a meal and can help you get to the right diagnosis. So I'm going to quickly mention pharmacologic provocation because it's really not as widely used, but the utilization of inhaled amyl nitrate, or CCK, can help you to better understand EGJ physiology and provide supportive information, potentially allowing you to decide if it's a primary EGJ outflow obstruction or a secondary EGJ outflow obstruction. So let's move on to our supportive test. And now a timed barium swallow, which we've heard a lot about over the past few days, can help provide valuable information to further support your diagnosis of EGJ outflow obstruction. And this test can give you a general sense of esophageal anatomy and also allows you to assess if there's any extrinsic or external compression. And a barium column height of greater than 2 centimeters at 5 minutes can distinguish between achalasia and EGJ outflow obstruction in non-achalasia patients. And an addition of a 15 millimeter barium tablet can increase your diagnostic yield for EGJ outflow obstruction and achalasia. And these are esophograms that correspond to manometric findings. And I'm going to call your attention to the middle picture here, where we can see that the proximal esophagus is filled with air, and the impedance signal here in the violet or purple is the liquid, and this correlates really well with the timed barium esophagram and the degree of barium retention here, and this can help you further support your data for an outflow obstruction. And this is actually our patient who had a video esophagram, didn't have a timed barium esophagram, but also had a barium tablet. And we can see here that the patient had a small hernia with a proximal ring, and there was complete impedance to passage of the barium tablet at the level of the ring. And so it was maybe this occlusive pattern that resulted in the manometric findings that we saw. And when we took the patient to the endoscopy suite and we dilated this patient, they actually improved. And I always like to say that treatment response, in my experience, is inversely correlated to the amount of portal messages that you receive. And I'll just say that I haven't gotten many portal messages from this patient after we've treated them. So let's move on to the flip. And we've heard a lot about the flip over the past few days as well. But basically, this is an endoscopically placed balloon-tipped catheter with impedance sensors that gives us some information on EGJ metrics as well as secondary peristaltic patterns. And the flip can provide the DI, which is probably the most investigated and useful metric here. And it's a measure of the narrowest cross-sectional area at the EGJ, as well as intraballoon pressure, and most normative data is collected at the 60 cc fill. And the contractile patterns here can correlate to manometric patterns where normal motility can be seen as racks or repetitive antegrade contractions, and repetitive retrograde contractions can indicate that there may be some spastic physiology within the esophagus. So if you see a DI that's less than 2 and you have a diameter of less than 12, this is definitely abnormal and fits more with an outflow obstruction pattern, where a DI of greater than 3 and a diameter of greater than 16 is likely normal and can provide some reassurance that maybe this isn't an outflow obstruction pattern. And so the classification of EGJ opening on endoflip has also become more detailed to allow for better characterization, but terms like reduced EGJ opening may be more suggestive of an outflow obstruction pattern. So this is a patient who has normal EGJ opening and a normal contractile pattern or racks. And this is actually a patient similar to the patient I initially discussed, with a very similar manometric pattern with reduced EGJ opening and an absent contractile response. Now, this typically could represent an achalasia pattern, but they did have a very similar manometric pattern to our patient. And when we did do a 20 millimeter balloon dilation, it actually looked like it was more like a peptic stricture. And the patient had symptom resolution right after when we opened it up. So with regards to management options, I think it's really important that you consider the cause. You need to address all potential reversible causes. You should exclude all medication effects or mechanical causes. And I think it's important to note that the Chicago classification version 3 recommended further investigation with an EUS or a CT for our patients with outflow obstruction. And this is no longer a recommendation unless alarm symptoms are present that prompt further investigation. Now, when we're thinking about options for therapy, I think it's also important to understand that less than 10% of these patients appear to progress to achalasia, and approximately 50% of patients appear to have spontaneous symptom resolution. So watchful waiting may actually be appropriate in these patients. But overall, when we're talking about options for therapy, the data isn't robust, and it's often without standardized outcome measures. Most studies utilize the Chicago classification version 3 because that's what we had, but now that we have more stringent criteria, we may not be dealing with the same kind of patient. There's no current RCT data to support options for therapy, and pharmacologic data is extremely limited and usually a kind of a hodgepodge when described, using multiple different medications like neuromodulators, PPIs, calcium channel blockers. We also have endoscopic management and surgical management, which I'll also get into. Now, in this study, actually compiled much of the data that we have on management options, and it looked at 8 studies with a total of 184 patients. And we can see here that majority of these patients were treated with expected management, and about 54% of these patients actually responded favorably. The most commonly employed therapy was Botox with about a 60% response rate, and pharmacologic therapies, again, all over the place with a number of different therapies, and was described as having about a 60% response rate. Pneumatic dilation, about 60% of patients responded favorably to, and smaller numbers for standard dilation and Heller myotomy, but also very promising. So I really want to quickly mention Botox because it could be a very useful tool in your armamentarium, and you can consider combining that with a 20 millimeter balloon dilation and endoscopy beforehand with a 20 millimeter balloon hand beforehand when you're doing an endoscopy. And in this study, looking at 36 patients who had impaired LES relaxation, we saw that more than 50% of patients had about a year of resolution, symptom relief with a Botox injection. So the benefit here is that you're not definitively altering the EGJ, and it may also give you a better idea of how patients respond to definitive therapy. And here's some data looking at POEM for EGJ outflow obstruction. And this, one of the larger studies looking at 55 patients who underwent POEM for EGJ outflow obstruction, about half of them were treated previously with medical and endoscopic therapies. And there was about a 94% clinical success rate, and about 66% of these patients, again, had abnormal pH monitoring post-POEM. And there were similar findings in this smaller study with 15 patients. So in conclusion, a clinically relevant and conclusive diagnosis of EGJ outflow obstruction requires a manometric diagnosis of EGJ outflow obstruction with the use of provocative maneuvers, multiple rapid swallows, rapid drink challenge, as well as increased intrabolus pressurization. It also requires the presence of symptoms that fit your clinical picture. Remember, obstructive symptoms like dysphagia or chest pain, and supportive evidence with the use of a timed barium esophagram or an endoflip. EGJ outflow obstruction can represent an evolving achalasia picture, but you should always consider secondary causes of EGJ outflow obstruction, and always think that maybe about 50% of these patients will have symptom resolution with expectant management. So you should really consider definitive treatments carefully, but you could consider a Botox injection for short-term relief, and this could allow you to assess their response to definitive EGJ therapy later on. Thank you.
If you could stay on stage, we'll have a quick Q&A. And Zubair, if you don't mind, if you could come up to the stage. If anybody in the audience has any questions, please come to one of the mics and ask them and ask your question. And while we're waiting for Zubair, let me ask you this. How often is Botox useful in EGJ outflow obstruction?
I mean, in my experience, I mean, we saw that the conglomeration of studies, it was about maybe a 50% response. In my experience, it actually really does help to buy me time. I've had a response rate of at least a year. And if there's patients that I'm hedging on, do I want to send them to POEM, or do I really want to offer them definitive therapy? It actually helps me to assess if there is some sort of response rate with Botox before I offer them a definitive therapy. If they do really well, then I'm less reluctant to send them to a definitive therapy, and I have a longer-term option for them.
So if somebody responds to Botox, would you be inclined to repeat it?
To
repeat it when their symptoms recur?
I think I just discuss it with the patient. Some people just really don't want to do this again, and they want a definitive therapy. But yes, I mean, depending on the patient, I could repeat it again, or I will just send them for a POEM.
Excellent. And Zubair, do you want to speak about sildenafil?
Sure. Sildenafil, I think, can be beneficial as some of these calcium channel blockers and nitrates can. But again, I think it's something that is really reserved for that patient that can't tolerate anything else. I mean, you may be able to speak on it better than I can, but I think it's just the durability and the amount of relief that they get is just not the same as with a more definitive therapy.
Yeah, the value is that it can completely block smooth muscle contraction, but it doesn't always translate into symptom relief. So
it's also really difficult to tolerate, right?
Yeah,
Patients who are really sick, it can cause significant hypotension. So.
Any questions from the audience? Go ahead.
Yeah, hey, Kevin Gillian.
Somebody's at the mic. If you don't mind, just go up to the mic.
I got lucky. I'm sitting right here.
So we're recording this, so we really want people at the mics. Go ahead, sir.
Good morning. Those were both very nice talks. The question, if people are doing expectant management, when do you bring them back maybe for repeat manometry? You do 6 months, a year?
It's really hard to get people to come back for a repeat manometry. I've had a manometry myself. But you know what? Depending on the patient, if they're willing to do it in a year, I bring them back in a year. But it's also, they'll doctor shop if you make them wait a year. So I do offer it at the 6-month mark. I have them come back and see how they're feeling. But they probably wouldn't commit to it for at least a year, just realistically speaking.
Okay, and I guess a similar question, how long do you think manometry results are valid? If you're going to send them out for definitive repair or something else?
Well, I think that's a good question. I think it depends on what your manometry results are. I showed you that patient that looked like they had an EGJ outflow obstruction pattern and then developed into a type 3 achalasia pattern. I mean, I saw them we saw them 3 years later, and so they had a completely different manometric pattern. I think our surgeons probably consider them valid for maybe 2 to 3 years. But it really just depends on what, like if they have a normal pattern, I'm not gonna repeat it unless there's a significant change in their symptoms.
Thank you.
Yes, sir.
So I'm Patrick Chasson from Tucson, a surgeon, and we see a lot of these patients as part of a GERD workup who don't have dysphagia, and we see EG outflow obstruction in them, and swallows will show hiatal hernias. And so what percentage of this manometric finding do you find just end up being just simply hiatal hernias being the cause of their outflow obstruction? And when they present with a GERD presentation with a positive pH testing, and this is their only finding, otherwise normal DCI, what kinds of recommendations do you make as far as anti-reflux surgery if this is sort of the road they're going down?
I think that's a really good question. We know that hiatal hernias can cause an obstructive pattern or an elevated IRP on manometry, and that's why you really have to use other supportive information to help you make that diagnosis. If they have a normal barium esophagram and their tablet flows throughly, I'm less inclined to think that this is a true outflow obstruction in a patient without dysphagia. And we have had patients that we send to surgery. We don't just anchor our information on just a one manometric pattern. We use a conglomeration of studies to help us make the diagnosis.
The point is that with Chicago 4.0, there are all these safeguards.
Right.
If the outflow obstruction is not confirmed in alternate testing or alternate position testing with the same manometry, and those are not real outflow obstructions. And some of the hiatus hernia situations may fit into that, especially if a tablet impacts at the hiatus hernia, then maybe the hernia needs to be repaired. We'll take 2 more questions.
Here you
so,
go.
Hi, Steve Clayton from Wake Forest. Just kind of wanted to remind the audience of a study that Joel Richter and I published in Neurogastro in 2019 showing the clinical utility of pneumatic dilation in the treatment of outflow obstruction. In our study, albeit the manometric diagnosis was made based on Chicago 3, the patients had to have symptoms and an abnormal emptying on time barium esophagram. In our study, symptoms improved over 70% of the time. We treated 33 patients with pneumatic dilation, and we had statistical significance in improvement in esophageal emptying on the time barium esophagram and tablet passage. And we had follow-up data for over 5 years where, basically no patients, progressed on to developing achalasia, and we had 0 complications. So. We started with a 30, but about 16% had to go up to a 35 millimeter balloon.
I completely agree with you. I think pneumatic dilation is a very reasonable option for treatment. I think the point is that you were very selective about who you chose. And up until now, a lot of people have been operating under the Chicago 3 classification with just an elevated IRP. You used a lot of the Chicago 4 classification factors with supportive information. And you're right, if you really hand select these patients, then doing a pneumatic dilation is helpful. But it really depends on who you're choosing for this before you definitively alter the EGJ.
Thank you. And last question, quick answer, please.
Yeah, quick question, sorry. Paul Cartwright from Columbus, Georgia. As far as opiates go, easy to say, sometimes hard to do, to say stop your opiates or SOL, type of thing. But do you know of any studies that treated people, either medication or pneumatic? I would assume not definitive, but with if they were still taking some opiates?
Yeah, I think real world, there's a lot of people that aren't going to come off their opiates. And so, I ask, you have to ask the patient, how long they expect to be on this. But if there's no way that they're going to come off of it, then, I'll treat them because this is their life and we want to improve their symptoms.
Yeah, there's huge population that can't come off their opiates for whatever reason, and I agree. Sometimes you just have to bite the bullet and do the treatment for them.
Wonderful. Thank you so much. Thank you for a very nice set of talks. Now we're going to move on. The next talk is going to be given by Dr. Crystal Lynch from the University of Pennsylvania in Philadelphia. Unfortunately, she couldn't be here today, but she has recorded her talk, and she's going to speak about distal esophageal spasm.
Good afternoon, everyone. I'm Crystal Lynch, and I will be continuing our talks this afternoon on esophageal motility disorders. Thank you so much to Peter, Josh, Rena, and everyone on the organizing committees for AFS for inviting me to speak today. The title of my talk is A Curious Case of Chest Pain. So our case presentation is a 65-year-old male with a history of non-obstructive CAD who presents to his PCP with intermittent dysphagia as well as chest pain. Symptoms have been ongoing for 6 months and they're not progressively worsening. He didn't have any weight loss, vomiting, regurgitation, abdominal pain, or shortness of breath, and his vital signs were unremarkable and his physical exams unrevealing. His PCP ordered a cardiac evaluation. His EKG was normal, as was his chest X-ray, and his stress echocardiogram was unremarkable. His symptoms did not respond to an 8-week trial of omeprazole 40 milligrams daily, taken 30 minutes before breakfast, and so he was ordered to have an upper endoscopy. Here we can see his esophagus. There's no evidence of strictures or narrowings, no masses, no evidence of pallor or furrowing, and no evidence of infection. His esophagus was biopsied throughout, and his stomach and small bowel were similarly normal. Here we can see his stomach on retroflex view and a Hill 1 GE junction. His esophageal biopsies returned with normal squamous epithelium. So then he was referred from his PCP for an evaluation from GI of esophageal spasm. So what do we mean as a medical community when we say spasm? Well, as a GI community, we know the spastic esophageal disorders technically include distal esophageal spasm, hypercontractile esophagus, as well as type 3 achalasia. And the distinctions between these diagnoses we know are made manometrically. So here is the most recent Chicago 4 classification. And when I think of spastic disorders, I sort of think of things on both halves of the Chicago classification. Sort of in my head, I think abnormal IRP or normal IRP. And so these disorders span across both sides. A simpler way to look at it is simply organizing these spastic disorders in a table like this, looking at the EGJ relaxation and the esophageal contractile pattern. So for hypercontractile esophagus, we know that patients have a normal IRP and at least 20% of swallows have a DCI over 8,000. For achalasia type 3, patients have an elevated IRP and at least 20% of swallows with premature contractions with a distal latency less than 4.5 seconds. These patients have no intact peristalsis. As for distal esophageal spasm, we know that patients have a normal IRP and at least 20% premature contractions with a distal latency less than 4.5 seconds. So what do we see on these manometries? Well, this shows hypercontractile esophagus, and I know that Joan is talking about this shortly, but just the 3 different phenotypes. You can see a single peak hypercontractile swallow on the left. So the DCI is still greater than 8,000. Jackhammer esophagus shown in the middle, as well as hypercontractile lower esophageal sphincter that you can see on the right. As for type 3 achalasia, we can see here that the LES is not relaxing with the IRP at 40.9, but the distal latency is less than 4.5. For distal esophageal spasm, we know that at least 20% of swallows with a DCI greater than 450 have a distal latency less than 4.5 in the setting of a normal IRP. So here's a classic example. We can see that the distal latency is 3.2 with a DCI greater than 450, and the IRP is normal, 12.1. One thing to note is that the contractile deceleration point is really critical when we're reading these manometries for DES. The CDP is the inflection point in the contraction front velocity in the distal esophagus. And so we know that that can be tricky to place, and it should be between 2 and 3 centimeters above the GE junction. So here we can see an example. The yellow dot is where the CDP was placed, and the distal latency of the swallow is thus 4.3 seconds. However, that was actually greater than 3 centimeters above the GE junction. And when you move it and correct it to be less than 3 centimeters above the GE junction, the distal latency of the swallow was actually 4.8. And so you can see that technique is very important, and the placement of the CDP can sort of make or break a diagnosis of DES. What about esophageal provocation? How does that play a role when we're trying to evaluate if a patient has DES? Well, we know here on the left, we can see that the patient underwent multiple rapid swallow sequence, and this particular patient did have a post-MRS DCI to single swallow DCI ratio of 3:2, so they did have contraction reserve. In patients who have DES, we often see lack of inhibition. And so when they undergo MRS, instead of seeing that inhibition until the end, we can see that there's actually esophageal contraction here during the multiple rapid swallow sequence. So that can indicate that patients have distal esophageal spasm or spastic disorders. What about other provocative testing, such as the rapid drink challenge? Well, in patients with spasm, we can often see pan-esophageal pressurization during the rapid drink challenge. And we also can see the shortening of the esophagus leading to a read here. We can see the dotted black line that the esophageal junction is moving up. So distal esophageal spasm is what we'll focus on today. It's prevalent in about 3 to 9% of symptomatic patients, and the mean age is around 60 years old. It has been reported to have a female predominance of around 55%. And it has a heterogeneous presentation. The most common symptoms are dysphagia and chest pain, followed by heartburn. DES may have many secondary causes, such as GERD, other medications such as opiates, and rarely EOE. And it's reasonable to consider advanced pH testing if there are classic GERD symptoms or other findings that make you concerned for GERD, such as grade C or D esophagitis. DES has also been linked to psychiatric conditions as well as psychotropic medications. So what about idiopathic DES, where we don't see any of these other causes contributing? The exact pathophysiology is unclear. It is thought to result from an imbalance between the nitrogenic inhibitory pathways and the cholinergic excitatory pathways in the myenteric plexus. And we know that it can evolve towards type 3 achalasia. So one study reported 14% of patients with DES evolving to achalasia. However, this study was limited because conventional manometry was used. So you can imagine that if there's esophageal shortening, there may be a pseudo relaxation of the EGJ as the esophagus moves, and perhaps these patients were actually misdiagnosed with DES when indeed they actually had a presentation more consistent with type 3 achalasia. Do symptoms matter? Well, we know that in the updated Chicago 4 classification, DES found on manometry is only considered clinically relevant if symptoms include chest pain, obviously non-cardiac, or dysphagia. So what other testing modalities can we look at for DES? Well, we know on barium swallow, we can see a classic presentation of a corkscrew appearance or beaded appearance. Additionally, there's often delayed passage of contrast into the stomach. So, this isn't a video, but we would often see that when we review the barium swallow. However, just remember that barium swallow is not actually specific for this. There have been multiple studies, but I'll point out one evaluation. It was over 100 patients, and though 61% of these patients had an abnormal barium swallow, only 4% had the classic beaded or corkscrew appearance in the esophagus. And these are all patients who are found to have DES on manometry. So EndoFlip can be used in DES. We know that it's an adjunctive tool in esophageal evaluation, and it uses impedance planimetry to assess cross-sectional area, pressure, and distensibility. So regarding EGJDI, FLIP could potentially identify, GEJ obstruction in the setting of spastic disorders. However, the esophageal body activity may also be helpful. So here we can see the main categories of esophageal body activity seen on FLIP. So on the left, we have RACs, so the repetitive antegrade contractions. Second is absent contractility, actually quite a similar appearance on manometry as well as phonometry. And then there's repetitive retrograde contractions as well as disordered contractility, which both can be indicative of spastic disorders. So specifically, we do see it in RRCs. So remember that repetitive retrograde contractions are 3 or more consecutively and consistently spaced retrograde contractions. It would reveal contractions about every 4 to 6 seconds, and it could suggest a hypercontractile or spastic motor process. What about management options for DES? Well, we know that concentrated peppermint oil has had some success, and medication-wise, smooth muscle relaxants are used given the pathophysiology, including lack of inhibition. Nitrates, phosphodiesterase 5 inhibitors, and calcium channel blockers are all sort of frequently used with varying outcomes. Another thought is to sort of target the pain that patients are having without necessarily changing their motility. And in that realm, tricyclic antidepressants have been used. And along those same lines, biofeedback therapy has been employed for this. What about other management options, perhaps endoscopic or surgical? Well, we know that Botox injection has been used, but the protocol is not standardized. Some providers are targeting the lower esophageal sphincter, some are targeting the esophageal body, and though success may happen in 50 to 100% of patients, depending on which study you look at, this is a temporary measure. Pneumatic dilation successes have been reported, but data is limited. And we know that myotomy, both POEM and laparoscopic color myotomy, have been successful. However, when comparing the use of these myotomies to type 3 achalasia, it is a little bit less effective. So coming back to our case, our patient underwent a barium esophagram as well as an esophageal manometry. And you can see his barium esophagram here with a classic corkscrew esophagus pattern. So manometry shown here, there's one representative swallow with a distal latency of 4.1 and an IRP of 10. 3 of the 10 swallows had a distal latency that was short, and the IRP overall was normal in both positions. So his findings were consistent with DES. He was actually started just simply on TID diltiazem. He was provided reassurance, and his symptoms improved at 1-month follow-up. So we have yet to see sort of longer follow-up with. In summary, distal esophageal spasm is a manometric and clinical diagnosis thought to be significant in the setting of dysphagia or chest pain. It can be secondary to psychotropic or opiate medications. A barium swallow may reveal corkscrew esophagus, but this is actually seen in the minority of patients with manometric DES. Treatment options include medication, botulinum toxin injection, pneumatic dilation, as well as myotomy. Here are my references. Thank you so much for having me. It's been a pleasure, and I hope you enjoy the rest of the conference.
Thank you, Chrissy. And continuing this theme of spastic disorders, I'd like to invite Joan Chen. Joan's an assistant professor of medicine at the University of Michigan, and she's going to talk about hypercontractile esophagus. Joan.
Good morning, everyone. Thank you so much for inviting me to give this talk, and thank you guys for sticking around. It's very special for me to be here. I told a few of you guys that I actually went to medical school at Vanderbilt, and we used to come here for our formals, and I'd only seen this place in the dark, so it's really neat to see it in the daylight and 16 years later. So I'm a lot older and hopefully a little bit wiser. But a quick apology. I did not get the memo that this was supposed to be case-based, so perhaps not much wiser than 16 years ago. But I know a lot of you have seen patients with this condition, hypercontractile esophagus, so I'm going to give you a second to kind of bring that patient into mind and as we go over hypercontractile esophagus today. So a quick word on the evolution of this diagnosis. The term, as you might recall previously called nutcracker esophagus, was initially coined in 1980 by Benjamin and Castell. And this was going to describe a condition of excessive peristaltic vigor. And the etiology was felt to be a combination of excessive cholinergic stimulation and possibly with impaired nitrous oxide inhibition activity. So the name has undergone many changes over the decades, and as I mentioned previously, called nutcracker esophagus. This was also then termed spastic nutcracker, then hypertensive peristalsis, then jackhammer esophagus in Chicago classification 3.0, and then most recently in 4.0, the term was kind of put back to hypercontractile esophagus. The definition has also undergone many changes over the decades, and starting from a mean peristaltic amplitude of 180 that was increased to 220. And then in the era of high resolution manometry, the equivalent vigor in DCI was 5,000. So that was initially used as the cutoff for hypertensive peristalsis. And then in a study including over 70 normal controls, it was found that DCI up to high 7,000s was seen in normal patients without symptoms. And so the DCI cutoff was then raised to 8,000. And in earlier iterations of the Chicago classification, we use greater than, or at least 10% of swallows with DCI greater than 8,000 as the cutoff for hypercontractile esophagus. But even with that threshold, we do still every once in a while see normal subjects with a DCI in that range. And so since the Chicago classification 3.0, the diagnostic threshold had been further increased to at least 20% of swallows with a DCI of greater than 8,000. So you've heard about the Chicago classification 4.0 over and over during this conference. So just a really quick reminder, this is the definition for hypercontractile esophagus based on the latest iteration of Chicago classification. And again, we emphasize conclusive versus inconclusive diagnosis. And so for conclusive diagnosis of HE, it is required that you have at least 20% of supine swallows with DCI greater than 8,000, but the DCI can include the lower esophageal sphincter. And I'll have a quick slide on that. It is also required to have the presence of clinical relevant symptoms, and it was felt that dysphagia and non-cardiac chest pains are the main symptoms relevant to hypercontractile esophagus. And it is also very important and critical to rule out the presence of achalasia, EGJ outflow obstruction, or distal esophageal spasm. And that leaves those with inconclusive diagnosis of hypercontractile esophagus, and these are the patients that will present with symptoms of dysphagia and chest pain, but only have 10% of swallows with DCI greater than 8,000, or they have a DCI somewhere between 5,000 and 8,000. So in these people, it is recommended that additional testing be done, and that might include barium esophagram, endoflip, or even repeating manometry down the road. So it's important to rule out obstruction because, as we know, distal esophageal or EGJ outflow obstruction can induce an esophageal body hypercontractile response. And this is nicely demonstrated by a study, and you guys have seen one of these slides earlier in Dr. Knott's talk, but this is a study that looked at a patient with a tight laparoscopic adjustable gastric band that with the elevated EGJ pressure also had a hypercontractile esophageal response. And once the gastric band has been deflated in this patient, you can see that the hypercontractile response is gone and they have normal peristaltic vigor with a DCI well below 8,000. So this is why ruling out obstruction is very important. It's also very important to rule out, or at least think about opiate-induced esophageal dysfunction, and this is because opiate users have been shown to have higher DCI. And in actually chronic opiate users, we have seen up to 16% of hypercontractile esophagus on high-resolution manometry. And in fact, among the patients that are diagnosed with opiate-induced esophageal dysfunction, hypercontractile esophagus is seen as the third most common HRM diagnosis after the diagnosis of diffuse esophageal spasm and EGJ outflow obstruction. So you've seen briefly the phenotypes of hypercontractile esophagus, and so this was recognized by the working group of the Chicago Classification 4.0. And these phenotypes include single-peaked versus multi-peaked hypercontractile esophagus, as well as LES-dependent versus LES-independent HE. And the single peak is seen, the single versus multiple peak requires no further explanation, I guess, but I'll just mention that multi-peak is seen quite common, and in one series, in above 80% of swallows or diagnoses of hypercontractile esophagus. Now, LES-dependent hypercontractile esophagus is more rare, and in one series it's about 15% of HE diagnoses. And basically what that means is that when you calculate the DCI in somebody with symptoms and the IRP is normal, when you include the analysis box, you include the lower esophageal sphincter in the analysis box, and that results in the DCI increasing to the range of hypercontractile esophagus, and thus giving the patient a diagnosis of LES-dependent hypercontractile esophagus. So a quick word on this. Again, hypercontractile involving LES, this finding has been observed in patients with symptoms of dysphagia. However, in a couple of studies now that have shown no difference in symptoms or outcome between patients with either LES-dependent or independent HE. So the working group had concluded that there's really currently no compelling evidence for subdividing HE into LES-dependent versus independent phenotypes. So there's no reason to see the table in detail, but this is one of the studies looking at the whether LES-dependent versus independent HE had any differences. And I'll just tell you here listed patient demographics, endoscopic and esophagram findings, as well as treatment outcome. And there was no difference with the exception of presence of hiatal hernia. So this is the diagnostic algorithm proposed by the working group for Chicago Classification 4.0 for diagnosis of hypercontractile esophagus. Again, those patients with at least 20% of swallows showing DCI greater than 8,000 in the absence of achalasia, outflow obstruction, and distal esophageal spasm, and in the setting of clinical relevant symptoms of dysphagia and or non-cardiac chest pain can be given a conclusive diagnosis of HE and can be considered for treatment for that. In patients without not meeting the manometric criteria, but do have 10% swallows with DCI above 8,000 or a maximum DCI between 5,000 and 8,000, and in the right clinical setting, these patients have inconclusive diagnosis. And in those people, we would consider additional testing, either barium esophagram, endoflip, or looking back at the manometry with the provocation maneuvers to see if we can add further evidence for the diagnosis. But notice that this is left kind of vague for, there's no specific criteria or, how these additional testing can be used to enhance the diagnosis of HE. So I do want to talk about that a little bit more. So as part of the standard protocol now, we are recommending provocation testing, including rapid drink challenge. And so in patients with hypercontractile esophagus, oftentimes we do see some abnormality, and whereas in the you can see in the top of the panel to the right there, in a normal rapid drink challenge response, you see deglutative inhibition, LES relaxation, and then that may or may not be followed by a normal peristalsis at the end of the sequence. In patients with hypercontractile disorders, we often see brief pressurization patterns, and that is also sometimes seen in patients with achalasia. So the bar graph here shows that when looking at pressurization after or during rapid drink challenge, the duration of pressurization and also pressure gradient across the EG junction, hypercontractile esophagus is somewhere between normal and achalasia. And that's pointed out by the yellow arrows there. The other provocation maneuver is multiple rapid swallows, and you guys have heard a lot about this, but again, it normally demonstrates normal or deglutative inhibition, and the multiple rapid augmentation as seen in a normal contractile response is seen in normal subjects. But in hypercontractile esophagus, we more often see a lack of the augmentation in abnormal contractile response, and more often we do see abnormal deglutative inhibition again. So this is seen in the bar graph here, where in patients with hypercontractile esophagus, we only see good contractile response or reserve in less than 50% in this cohort, and also abnormal inhibition during multiple rapid swallows. What about flip panometry? It is becoming a tool that is more and more used in the motility lab by us, and so this has, it only been investigated in sort of the earlier stages, but in patients with hypercontractile esophagus, we do frequently see spastic reactive contractile responses, and that includes sustained occluding contractions, sustained LES contraction, or repetitive retrograde contractions. We also often see abnormal EGJ distensibility. So in the top right panel, you can see that this is a patient with hypercontractile response, but with a flip panometry that looks a lot like type 3 achalasia, where there are repetitive retrograde contractions seen and a very tight EG junction with abnormal EGJ-DI. And then in one of the manuscripts on this, several examples of patients with hypercontractile esophagus was included with their HRM and panometry findings. And so you can see that there are different patterns that can be seen on panometry in patients with HE. And that can be, in the first example, somebody that really has no discernible contraction, esophageal body contraction seen, or a secondary peristalsis seen, and again, tight EG junction with abnormal EGJ-DI. In the second patient, we see antegrade contractions, but kind of in a slow, definitely less than 6 per minute pattern, and also these more sustained occluding contractions. And then in the third patient, you can see more prolonged occluding contractions and abnormal LES relaxation, and with the esophagus that looks like it was shortening with the LES being pulled up into the chest. So these are all patterns that are seen in patients with HE, but it's not one distinct pattern. And for now, panometry can be used mostly to roll out a normal motility, but in terms of abnormalities, there's not one distinct pattern for diagnosis. So I wanted to come back to talk about the clinical relevance of HE, because this is why this diagnosis is kind of a conundrum oftentimes that we come across in our clinic. The reason why HE is difficult to manage is because this is a very heterogeneous group, and much like what we had talked about in EGJ outflow obstruction and in spasm, this group have variable symptoms and variable outcomes. It is very rare with a prevalence of 2 to 4%, and the symptoms poorly associate with manometric parameters, although in some studies there's been correlation between the DCI and dysphagia symptom, DCI and IRP with dysphagia symptoms. Overall, it doesn't correlate well, especially with treatment outcome. And so our studies that we have available are mostly retrospective studies that are uncontrolled, and also we're relying on case series, in the literature. And then to add to that, there are also reports of spontaneous symptom resolution at follow-up without treatment. In this study, they did combine EGJ outflow obstruction and hypercontractile esophagus, but as you can see, whether there was treatment or no treatment on the patients, at 3 years, a lot of these patients had spontaneous symptom resolution. So this makes the diagnosis difficult and treatment difficult. But a few things to keep in mind is that, first of all, it's important to roll out the trigger, as I mentioned, of GERD, opiate-induced dysmotility, EOE, EGJ outflow obstruction, and then just keeping in mind that some of these patients have symptom resolution, whether we do any treatment or not. There are pharmacologic options that Dr. Lynch had mentioned in both spastic disorders and hypercontractile esophagus that we could consider, and those are the calcium channel blockers, nitrates, phosphodiesterase inhibitors, and neuromodulators for symptom control. And then there are endoscopic or surgical options that can be used, such as pneumatic dilation, botulinum toxin injection, or peroral endoscopic myotomy. And so these are all options for treatment in the right patient setting, and I would say that treatment will, plan really has to be tailored in the patients with significant symptoms, and also with manometric diagnosis, but also supported testing that supports the diagnosis of HE, warranting treatment. So looking at treatment outcomes, again, there aren't a ton of outcome studies on HE, but there is a French HE cohort recently published that showed only about 14% responses and 35% partial responders to medical treatment. And then in a meta-analysis, which result looking a little bit better, 63% of HE patients achieved clinical improvement after medical treatment, and nearly 80% after endoscopic treatment, and 82% after POEM. With regards to use of Botox treatment in hypercontractile esophagus, in the French cohort, it had looked like it fared better than pneumatic dilation, with 57% recurrence rate after pneumatic dilation, comparing to 31% after Botox injection. But in a more recent double-blind randomized sham-controlled study, Botox injections was actually not superior to sham in improving symptoms related to HE. And you can see that overall the patients, whether sham or Botox, did have symptom improvement, but there's really no difference between the two groups. And again, symptom outcome between Botox group and sham group are pretty similar with no significant p-values. And then the role of POEM. POEM has been shown to reduce esophageal body contractility, and the pooled response rate from the meta-analysis showed POEM success rate above 80, so 82.3%. But really long-term response data of POEM and HE is currently not available. So I'm going to summarize my talk by putting together some future directions. We need more longitudinal studies to understand the natural history and impact of HE, and the roles of either HRM provocation testing and the use of novel esophageal physiology testing, such as EndoFlip, should be better defined. We also need better designed therapeutic trials, controlled trials, and with long-term follow-up to know how best to treat these patients. And when it comes to the HE phenotypes, we should look at outcome studies to see if there's a difference between the phenotypes, to see if tailored therapy makes sense for the different subtypes. Thank you for your attention.
Thank you, Joan. And if you don't mind staying up there, we'll do a quick Q&A. Go ahead, please come up to the mic.
Hi, Brad Smith, Bemidji, Minnesota. I'm a PA, work in general surgery. Thanks to everybody that contributed. This has been invaluable information. And maybe I'm going to ask too basic of a question, but I'm trying to connect the symptomology. One theme of this conference has been pay attention to the symptoms. You know, you got all these symptoms. We're not going to fix them all with a Nissen. The patient needs to know that. So symptomology, patient chest pain, rule out cardiac, comes to me for a manometry. Happens all the time. Maybe I diagnose them with esophageal spasm, or maybe I don't. And we're looking at we're looking at swallows on our manometry study. They don't have symptoms, but yet their symptomology over here is non-provoked, prolonged symptoms of chest pain. Where's the connection? What's happening in the esophagus for this 30 minutes of chest pain? Is there a way to help me understand that? Or is this a
No.
rhetorical question?
No, that's a very good question, and I'll let Joan take that, and I'll contribute as well.
I think that's always hard. I mean, we have a lot of tools in esophagus, but it doesn't always mean that what we see during the 10 minutes of manometry testing reflects what's happening outside, when they're having pain. In people that you're not, I think your question is that you're not seeing it during manometry, but they are having symptoms, or
This patient has a half an hour of chest pain, not eating and drinking. What's happening inside the esophagus, or where's that pain coming from?
So I think without the manometry, I'd be hard-pressed to say that it necessarily is related to either spasm or hypercontractile esophagus. There are other causes, and actually reflux is something that needs to be rolled in or rolled out with reflux testing, because it is more common as a cause for non-cardiac chest pain of esophageal origin than it is motility disorder. So that's one thing. And years ago, we had looked at doing 24-hour manometry studies, and you talk about patients not liking a 10-minute study. A 24-hour catheter, 24 hours overnight is just not really feasible. But ideally, if we can have longer testing periods, maybe catching them during the symptom, it might show us something differently. But I don't know if you have any.
There are a couple of concepts regarding this that can help decide what to do, what you can do. And it's really based on the frequency of different pathophysiologic mechanisms when somebody has chest pain in particular. It's a chest pain. So you got to think about these symptoms as being either perceptive, patient says, I feel, or obstructive, things don't go down. It's important to separate those two. The obstructive symptoms have something going on in the esophagus, but they only happen during meal times. So obstructive symptoms are very different from perceptive symptoms. And what you're describing is a perceptive symptom. So when you take perceptive symptoms, obviously heart, we are going to go with heart first. It doesn't matter what the perceptive symptom is. You don't have a good explanation. You've endoscoped the person, that's heart. Sometimes even before endoscopy, if it's chest pain, right? When you've ruled out the heart, if you look at the spectrum, the biggest next group is reflux. That's the biggest next group. You may not catch it with a 24-hour study when patients don't have daily symptoms. So that's your situation where you probably place a 96-hour pH monitor off PPI, so Bravo off PPI. That's your biggest bucket, right? Beyond that, the next buckets are things that you might have seen during endoscopy or picked up on biopsy, so inflammatory, EOE, that kind of stuff, but also motor disorders and functional disorders. And when it comes to motor disorders, these conditions that we talk about, the distal esophageal spasm, hypercontractile esophagus, it's sometimes even type 3 achalasia. The mechanism of symptoms is esophageal hypersensitivity. It is not really the actual spasm during that time. It can be sometimes, but not all the time. So if you take everybody with a motor disorder and try to treat their motor part, you destroy their ability to contract, most of them will still have pain. So it's well worth working down the perception pathway by using neuromodulators first, rather than try to do something irreversible by cutting the muscle. So those are some paradigms that you can use in patients like the one you mentioned. And if that patient did not have access to investigation, I'd give them a PPI, didn't get better, give them a neuromodulator, and do behavioral therapy, get rid of their opioids, that kind of thing. So hopefully that was useful.
So I'm Patrick Chesno, again, another surgeon, and so I'm going to throw this is even a little bit more complicated. So patient referred by an ear, nose, and throat physician for GERD/LPR, sort of initial evaluation, 96-hour pH, Demeester score of 12, correlation between heartburn symptoms and reflux. Went on to do manometry and Diversitech 24-hour pH impedance using the LPR probe. Patient has 3 episodes of reflux above the UES in that 24 hours as far as 10 full column reflux episodes. So initially treated with nitrates, and then, finally the manometry demonstrated at DCI average of 8,500 with a normal IRP. So hypertensive esophagus, findings suggestive of LPR, not responding to PPIs, not responding to nitrates, still complaining of LPR type symptoms.
So I would throw out the term LPR in there and figure out what the symptom is. If the symptom is hoarseness, or if the symptom is a discomfort, you're describing a functional patient, because they have reflux hypersensitivity. Your acid exposure is normal, you have symptom reflux association, your Demeester is 12, which means your threshold is below ones that we would use for conclusive reflux. So acid reflux is out the window, doesn't have it. They have acid-induced symptoms. That's why you had symptom reflux association. And the hypercontractility, or the exaggerated contraction you've seen, is an epiphenomenon for esophageal hypersensitivity. So this person, I would send to Dave Katska for some of these behavioral therapies. I would use, and you'll hear about them later, I would use neuromodulators. If they didn't respond to a PPI, it's because they don't have a whole lot of reflux, so I would not treat them with a PPI. So for the ENT group, sometimes speech therapy helps these patients. That's a version of behavioral therapy. Diaphragmatic breathing can help. Hypnotherapy. These are all techniques that can help a patient like that. Not a patient to wrap. That patient will do horribly if you wrap them. Anything to add?
I agree. I mean, LPR is a very controversial diagnosis, especially when you have a room full of gastroenterologists and surgeons. I see these patients all the time, though, and it is I think part of our job is to try to not over-treat these patients, right? Because they'll end up getting, home, in some instances, and make their reflux worse, right? And so based on the criteria, that is not somebody that I would recommend treatment directed at the hypercontractile esophagus.
Casey Graybill, surgeon from Gainesville, Georgia. I appreciate the reference to the hypertensive esophagus extending to the LES, because I've struggled with that. I've recognized it as a manometric pattern, but not necessarily as a phenotype per se, and have typically considered it noting the elevated IRP with interest, but looking back at the tracings and thinking this is somehow artifactual extension of peristalsis into that zone. So physiologically, help me understand what you think distinguishes those patients from those where the hypertensive pathology does not extend to the LES. How do I integrate that with what I understand about LES function?
So that's a great question, and I think the short answer is we don't know. From what the data looks like, they are indistinguishable between the two subtypes, but it's probably still relating to the excessive cholinergic activation and maybe decreased nitrous oxide activity. But we don't really know how physiologically, how pathophysiology is different between the groups.
And there are some hypotheses. And the thing to remember here is, I think this is a very important point, the continuum of motility disorders, the continuum of motor disorders, right? So you have EGJ disorders, and the EGJ disorders we recognize because the LES does not relax, right? The relaxation errors. We call them achalasia spectrum or EGJ outflow obstruction. Then we have esophageal body disorders in that same vein. More contraction, exaggerated contraction. We call them spastic disorders. So if you have somebody with a hypercontractile esophagus and a non-relaxing LES, we call that EGJ outflow obstruction, not hypercontractile with obstruction. That's a misnomer, but you can see that combo. You can have somebody with distal esophageal spasm and abnormal LES relaxation. We call that type 3 achalasia. So there is a link or a continuum between these disorders. And most people believe that this happens because there is some derangement of the neuronal plexuses in the esophagus, so that there is an imbalance between excitation and inhibition, right? If that imbalance exists only in the esophageal body, you get distal esophageal spasm if the inhibition is more involved than the excitation. You get hypercontractile if dampening of inhibition is combined with exaggerated excitation. Now, if that process somehow involves the LES only on the excitation side, you get what you're describing, extension of that process to the LES or isolated LES hypertension or hypertensive LES. That relaxes, right? If you have more of an inhibition error, you get EGJ outflow obstruction within the achalasia spectrum. Now, why does that happen at all? People believe that this is probably a situation where a virus or some other environmental trigger generates antibodies that somehow attack the esophageal neurons. So there is some limited evidence for that. There is also this interesting pathophysiologic hypothesis that eosinophils have something to do with it. But we're only beginning to scratch the surface of what exactly is happening. What is most important in the patient is to follow that patient, because they may be an early manifestation of something much more significant. And what is significant in the esophagus? Motor obstruction, because we can treat it. Last question.
Hi, thank you for all the excellent presentations. I'm Priyanka Sachdeva, a community gastroenterologist outside of Philadelphia, trained at Temple. I'm still trying to understand the role of endoscopic ultrasound in the evaluation of esophageal motor disorders. Any help with that?
No.
There's quite limited data on that when it relates to hypercontractile esophagus. I think there are only case reports. We're not necessarily rolling out infiltrative cancer like we used to think we should do in EGJ outflow obstruction. But some of the endoscopic ultrasound findings have been thickened muscularis layer, and in some case reports of eosinophilic myositis, as Dr. Gawali had mentioned. But I don't have that in my clinical practice. It's more, I think, research-based that we do endoscopic ultrasound in hypercontractile or spastic patients.
Yeah. Not routine. Only if you have something atypical. So somebody has lost weight very rapidly, or you're worried that there is something else going on. The endoscopy looks a little wonky, doesn't look right. That's when you would ask for cross-section imaging. Actually, I'm going to let Dave make a comment. Would you mind coming up to the mic?
Thank you, Prakash and Joan Zubair. Read wonderful talks. I've learned a lot this morning. I'm at the age where I can put out these theories and not get booed off the stage, so I just want to expand on a couple of things Prakash has said. One is that when we think about the ganglionitis, there are sensory nerves in there. Yet we only think of this as a motor disorder. And I think it's very important to reinforce what Prakash said. This is still one of the frontiers we have not explored, the sensory dysfunction and motor disorders. Iko Arano did studies years ago looking at achalasia, showed early on they do have a hypersensitive esophagus. Was that acid or balloon distension? I'm trying to remember, Prakash. But we don't think about that, so a lot of the treatments we use for the pain is more sensory, duloxetine, low-dose tricyclics, Neurontin, Lyrica, things like that, as opposed to trying to always wrestle with the motor problem. The second is that, as Prakash said, we classify these diseases by manometric abnormalities because that helps us take care of these patients better. But this is a pathologic disease. And if I took 10 patients with achalasia type 2, the pathology would look totally different on all 10. And so the idea that we're trying to interpret what really a very variable ganglionitis, depth, how many ganglia are injured, how many are not, how much of the esophageal body is involved, we have to remember this is very much a continuum of a disease, an patchy, unpredictable disease, as opposed to, but we have to blend that concept in with our desire to make this a highly classified disease. Thank you.
Wonderful. Thank you so much. And with that, we're going to take a short break. We'll resume at 10 till 10. We'll change tack there with that session and talk about reflux. So thank you very much. Welcome back, everybody. Just to keep us in time, since this is Sunday, we'd like to probably move on to the next session. We're going to change gears a little bit and talk about reflux disease. And I'm going to invite Phil Katz to start this session off. Phil's a professor of medicine. He's a past president of the ACG. He's the editor-in-chief, one of the editors-in-chief of the Foregut magazine, a journal that the AFS has started. And Phil's going to talk to us on management of the typical GERD patient. Thank you, Phil.
Thank you, Prakash, and good morning, everybody. I feel badly that I missed the first session because I probably would have learned something, but I was at the AFS board meeting, and in many ways, this is an opportunity to give a small number of you personal thanks for coming, because we are very excited about the meeting and the society, and hopefully you will give people good feedback or bad feedback or any feedback so that we can expand our offerings. So I am a consultant for Fathom Pharma. I'm not going to talk about PCABs today, simply because I'm not. But you can expect that they will be coming. So when you're assigned a topic, either you ask the course organizers what they really want you to address, or they tell you what they would like you to address, or you decide what you're going to address. So I'm going to talk about the typical patient in the sense that the person after me is going to talk about the atypical patient. So I apologize, Walter, if there's overlap, because we didn't really necessarily talk, but in this case there will not be a problem if that's the case. Now, most people look at slides and don't necessarily listen unless they're talking about the same thing. Now, I put up this definition of GERD. I put up this definition of GERD in part because I think that Montreal needs to leave. And this definition, as you see, incorporates symptoms, and it incorporates objective findings. And we're moving to understand that while objective findings in the esophagus are not always present, that between the endoscopy and a well-defined physiologic workup, you can make an objective diagnosis of GERD. And I think that's part of what people should be talking about when they talk about management of either typical or atypical disease. Make a diagnosis. Now, this will appear in print somewhere soon, and variations of this have appeared in print before, but it's something that I don't like, but seems to be necessary today, which is an algorithmic approach to a disease. And as you take a minute to look at this, and remember this will be recorded so you can come back and look at this, and there's no reference on the slide for embargo reasons. There is a difference in my mind in the workup of a patient with heartburn and regurgitation without alarm symptoms and other forms of presentation of esophageal disease. A typical GERD patient can, in most quarters, start with a PPI trial. We'll argue that for 100 years, but I think that's where we are today. And that our branch points revolve around relief and incomplete or no relief. And to me, the incomplete relief is relatively uncomplicated. Evaluate the patient. Evaluate the patient. Don't switch PPIs 1,000 times. Don't double, don't triple, don't quadruple. Evaluate the patient. And there is a push amongst us who do this every day to try and evaluate the patient off PPIs for longer than a week, that we tell people to be off for a pH monitoring study. The reason being is that there is some indication that if you can be off for 2, 3, or 4 weeks, that you might actually relapse. And then you confirm GERD by the presence or absence of mucosal injury and a physiologic study that involves, at the beginning, reflux monitoring. Now, I'm going to expand, A, because this is an advanced course, and B, because I'm going to assume that you all are not medical students and have some background knowledge of this. And that to me, what a gastroenterologist does is to manage refractory symptoms, and what a surgeon does is to manage refractory symptoms. There are a few people who come to one of us for the first time and have never seen medication, but it's rare. So you're seeing two branch points of patients, and the surgeons in the room, I think, are seeing a similar branch point or a dichotomy. It just depends upon your practice. Sometimes you get lucky and you get scenario 1 and you get objectively documented GERD and the patient just doesn't like the way the drugs are working. And then scenario 2, which is all too common and needs to go away, is that a patient with suspected symptoms due to GERD has been treated empirically, but the symptoms haven't been relieved to their satisfaction. So there are two types of refractory GERD, and both can be related to heartburn and regurgitation, and the approach may be subtly different. But ultimately, the question to answer is the same. Are the residual symptoms due to GERD, and if so, why? Same as in the original workup. When you see a patient who has yuck, you got to figure out whether that yuck is reflux, and the PPI can't be the only arbiter. Now, Prakash led a writing group on a wonderful guideline on the physiologic testing indications and guidelines, and they don't completely revolve around GERD, but they dovetail with an overview guideline, which has been rewritten, and part of the context of that is what has changed since the last guideline. And although there are subtleties, they're not small. So we know now that the PPI adverse event mandate has changed our thinking towards other options for treatment. And if you listen to Moietti's talk and you have my bias that all of those things are not really important, it doesn't really change the paradigm that people don't want to take medicine forever. There is now level 1 evidence that Nissen fundoplication, magnetic sphincter augmentation, and TIF can treat patients with GERD. And in the case of the first two, at really strong level evidence, and at the second one, maybe not as strong, but good stuff coming. There are a few outcomes data studies. They're not randomized in the truest sense on optimizing PPIs there's a greater understanding of reasons for incomplete response to medical therapy, and we have clearly shifted in part because of Prakash's leading with Sabine Roman and the international working groups into the more judicious and frequent use of objective diagnostic testing, which I think you wouldn't be here if you didn't care about that, but that's an important thing to push. Now, there are a lot of different determinants of symptoms. Heartburn can be produced in many different ways. I heard a brief end of discussion about esophageal sensitivity. You're going to have a whole session on non-pharmacologic interventions for symptoms, and it's important. And the only but is that it is still pretty clear that acid causes injury. Acid plus bile probably causes more injury than acid alone, but we can't measure bile. And that weakly acidic and non-acidic material does cause symptoms. Timing of reflux matters. All of these things are important to put into picture of why people get heartburn and regurgitation that doesn't respond to a PPI. So when you have a patient with heartburn and regurgitation refractory to treatment, you got three major possibilities, okay? There's some alteration in either anatomy or physiology or sensitivity that is causing the symptom, and you have to dissect that. GERD may not be the cause of residual symptoms. We don't have time to talk about who has EOE, who has GERD, who ruminates, who regurgitates, who has aerophagia, and where gastroparesis fits, but they all play the game. And then flat out, a whole bunch of people just don't have GERD, and that's where the testing comes in. Now, I'm going to spend a few minutes on a topic that is very dear to my heart, and you heard Gary Falk talk, I don't know, yesterday or the day before, Prakash, I can't remember. He cited a very nice erudite article by David Graham, who basically took all of the rest of our data and put it into a more common article. All of the studies were done before he ever thought about putting them together. And that's my little sarcasm for people who forget about history. But there are many reasons why PPIs don't control gastric acidity, and whether you are surgeon, gastroenterologist, mixed, whether you are on the front line as a physician, practice partner, as an NP or a PA, dose timing relative to food is not optimal. It's still important. You still can't take a PPI before you go to bed and expect it to work as well as to taking it before dinner. The dose is insufficient. There's very little incremental advantage over twice-a-day PPI, but they're not all the same, actually, in the test tube. And there are a few people, maybe 2 or 3 or 4%, who really do need double-double to get acid control. Now, I'm not saying I would do it, but they can. The genetic variability is still not measurable in a way that is practical, but it just needs to stay there. H. pylori does have some effect on PPI efficacy in the test tube. Infected patients have much better control of gastric acidity than patients who are not infected. And in a world in which we have been accused of and have probably forgotten some of our underserved patients, the reality is that H. pylori may affect your therapy in such a way of how the drugs work. Nothing more than that. Now, it is important to remember that once daily PPI does not abolish acid secretion, and that all PPIs may be the same in 10, 15, 20, 40,000 patient series, but in all of you in this room, they're all different in terms of how they control intragastric pH. So pantoprazole in this study that we did almost 19 years ago now was the worst. Now, I don't know what the worst means, but it's a number, okay? And if you cross these people over, as this study did, where everybody got all 5 of them, not everybody was better with esomeprazole. Some actually were best with pantoprazole. So, study the patient, okay? Listen to precaution, how you put in these pH probes and where you should put them and how many electrodes you should have. The acid part of this is not trivial. even as we try to understand the value of impedance and looking at height and weakly acidic reflux. Timing relative to a meal makes a difference in acid control. If you take your PPI before breakfast and you actually eat, your acid control is better than if you don't eat breakfast. It's just as simple as that. The optimal time, I don't know. 5 minutes, 10 minutes, 30 minutes, an hour before. Can play with a lot of pharmacokinetic issues, but the reality is if you don't eat, you don't get as big a bigger bang for your buck because you don't activate pumps. And that's the easiest way to remember the importance of food. If you don't remember before, take it after. Some of them get affected if you take it during, so that's usually not what I recommend. And not before bed, not before bed, not before bed. Not before bed. Everybody uses it before bed. I take it at night. What's night? Before I go to bed. No. Night is before dinner. If you don't eat dinner, so be it. No studies in people with altered shifts, people who work 4 to 12, people who work 12 to 8 nights. All the studies are breakfast at 8 in the morning, dinner at 6. That's where the pH data come from. 8 in the morning, dinner at 6. The evening dose loses its efficacy at about 1 in the morning if you take it at 6 p.m. Count the hours and think conceptually, okay? BID at the same dose as orally is better. So 40 of omeprazole in the morning, better split 20-20. Harder to take, but better acid control. Those principles, in terms of managing a patient with heartburn or regurgitation, heartburn is important, okay, to me. And to your patient, too. Now, there probably is a threshold, a study that we don't really look at very often ever, but at one point in time, AstraZeneca, while they were trying to truly prove that Nexium was the best drug on the planet, had this idea that if they could correlate intragastric pH control with healing, it would emphasize their marketing message, and it makes sound clinical sense to see if that's the case. This study looked at healing of C and D as a function of intragastric pH control at day 7 on either 10 milligrams of esomeprazole or 40. And the study looked at pH control and healing, not the dose. The dose was irrelevant, but we needed a control. And you can't think about 10 milligrams of ESO because you can't find it. And you see that there is a curve, and then there's a plateau. That plateau is at 16 hours, 17 hours, 18 hours a day. I think it's real. Again, more food for thought as you're thinking about a high level. And then Kyrillos' magic with slides. He's nice enough to let us all steal his magic. He makes them very, I won't say pretty, but that's what it looks like to me. Anyway, and it shows you that the therapeutic gain of PPIs over placebo is different pending the symptom. And Walter's stuck with talking about the atypicals. I got the easy job, thanks to giving the older guy the easier way to go. Heartburn and erosive esophagitis, that's a pretty easy one to get, but the people with non-erosive disease, which needs to be redefined, don't do as well as people with erosive disease, and that's very complex. We're not going to talk about that in any detail, okay? But to stay on time, I'm going to be brief just to bullet point some of these things, okay? This slide obviously didn't translate to this background, and I apologize for that. But if you look at the total number of reflux episodes on the y-axis, no treatment, and on PPI here, this is a 2-hour study. You ate a nice big refluxogenic meal, you laid down and got to have reflux measured with a tube in your nose for the next 2 hours. And we divided it into acidic reflux, pH less than 4, and non-acidic, which back then was just greater than 4, okay? So no weakly acidic. And what you can see is that the number of reflux episodes is statistically the same. So PPIs do reduce gastric volume, but not reflux itself, hence the mechanical need to think about this disease globally. And then when you extend that to symptoms, heartburn, acid taste, and regurgitation, that the non-acidic or neutral contents or above 4 can generate symptoms in a very small group of people, okay? 20 years ago, these studies, some ways they probably need to be repeated. So efficiently, here's a short study published in DD&S about 2 years ago, 64 patients, heartburn on BID omeprazole, not taken optimally by history. They were randomized to optimal control or to continue doing what they were doing, and at 8 weeks there was a significant decrease in frequency and severity of symptoms on an optimal regimen. More importantly is the evil speckler. Now, to surgeons, speckler's evil. To gastroenterologists, speckler's a genius. And somewhere towards our side is probably more than true. But Stu, once again, has led a VA trial that was published in the New England Journal in 2019. I reviewed this trial for the VA. It took a very long time to fund. It took a very long time to do. And it's very complex. But the principles are irrefutable, and that's why I believe it got published in the New England Journal. 366 patients enrolled for heartburn refractory to medical therapy. 70 discontinued owing to being unwilling or unable to complete the pre-randomization procedures. That's not VA noise, that's real life. 54 were excluded for miscellaneous reasons. And 42, which is where the arrow is, had PPI responsive GERD and improvement in their GERD HRQL simply by optimizing their omeprazole. Small percentage, but not trivial, okay? 42 out of 366 is not a huge number, but if I could get that every day, Prakash, I'd be pretty happy, right? You can decipher a whole bunch of people. Then a fair number of people had other organic diseases, but the principle of this part of the slide is that optimization works, okay? Now, fundoplication, in this case Nissen, because that's what the study did for refractory heartburn, okay? And again, moving down this study, this is a group that got evaluated at the end of a year. The endpoint was GERD HRQL, tricky, okay? And what you had to do to get in this study was ridiculous. Look at all of that there. Bottom line is you had to have continued reflux, acidic or non-acidic, or a sensitive esophagus based on symptom index. No argument about flaws, because there's a flaw in every study. You can always criticize, as Reg Bell is kind enough to say. And there are 78 with reflux-related PPI refractory heartburn. And not to any investigator's surprise, 2/3 improved with surgery, which was superior to active medical treatment. Now, to me, that's because we have crappy medical treatment and because the surgeons are good. But a clear example of the importance of dissecting the patient, okay? Set expectations about transoral fundoplication, okay? The best level 1 evidence, trial too short, but not their fault. 6 years old now, well worked up, Peter Karillis designed trial, John Hunter lead surgeon, very, very good investigators, small hernias, no big erosions, normal high resolution manometry, TIF versus sham, BID, final evaluation at 6 months, and the TIF patients did better than BID PPI. 5-year follow-up, uncontrolled, says staying power. 10-year follow-up, even less controlled. You need some time with this slide. Some people didn't need a PPI 10 years later. And the top line is that somewhere between 2 and 7% had complications, and I don't see a problem going on to a Nissen after you do a TIF, as long as you ultimately get better. So we're beginning to understand a little bit more about our alternatives for heartburn and regurgitation. I'll close with magnetic sphincter augmentation. Again, a randomized controlled trial published in GIE in 2019, refractory to PPI daily. You had an abnormal pH study off, normal HRM, maybe we can talk about all of this in discussion. MSA versus PPI-BID and a crossover, and there's the meat. Okay, so MSA, 80% had no regurgitation at the endpoints measured, as opposed to almost the opposite for BID PPI. Remember, this was randomized, it was blinded. And I'm not sure how you can completely blind it, but you could. And then they actually crossed over, discontinue a medication fairly high in the MSA group. Level 1 evidence that you can do very nicely in a true refractory population with an operative intervention. And I'm going to skip that in the interest of time. And then finally, which is not the end product of this, it should be the front end. If you carefully work these people up, functional heartburn, 32% on the right-hand side, 9% functional chest pain, a couple of people with rumination and some motility abnormalities in the group. Work the patient up, work the patient up, work the patient up, figure out what they've got, and then use the menu. I do thank you, Prakash, Reina, who's not here, and Josh for putting together this course. You'll see this algorithm very soon that allows you to think about how we think about the management of symptoms suspected due to GERD. Again, this is embargoed, so that's all I can show you. I thank you all for listening.
Thank you, Phil, for that masterful presentation. And we'll move on. I'd like to invite Walter Chan. Walter is an assistant professor of medicine at Brigham and Women's, and he's done a lot of work with atypical GERD, and he's going to talk to us about atypical GERD management.
Thank you, Prakash. This is probably a group of patients we see more and more these days, partly because the treatment for typical GERD has been so good that I think the proportion of patients we see coming in our clinic with atypical symptoms are probably become more frequent. I think there's some questions earlier about them too. So I'm going to try to go over a little bit about what we currently know, especially with regard to diagnosis. We know that GERD can be classified into those with more esophageal symptoms and those with extraesophageal symptoms, and the ones that we're going to focus on during this talk are the extraesophageal symptoms patients, mostly with airway complications. And there are challenges with this group of patients. First of all, a lot of these patients don't have classic esophageal symptoms like heartburn. They just come in and throat symptoms or airway symptoms. Their presenting symptoms are not specific. They might have cough, they might have hoarseness, they might have, just kind of secretions or mucus sensation that they might complain about. The airway may be more sensitive to acid exposure than the esophagus. We have certain definition for what is considered pathologic reflux from an esophageal standpoint, but our airway might react a little bit differently. There have been some studies that as few as 3 episodes per week of reflux going to the larynx may cause significant inflammation or injury, and that might be enough to cause symptoms itself. So we maybe need to be a little bit more sensitive to that. And then there's also the questions of reflux versus reflex. We always think about extraesophageal reflux being refluxate coming all to the airway, causing microaspiration, leading to injury and symptoms. But there's also maybe a reflex pathway where reflux coming to the esophagus trigger a neurological or vagal stimulation that leads to airway spasm, causing throat symptoms. So we need to be thinking about that as well. And the biggest challenge is that there's currently no diagnostic gold standard. So that's why a lot of my talk is going to focus on how can we diagnose these patients and pick the right one to do reflux therapy. So I'm going to start with a case of a patient, probably very familiar, a 40-year-old man, no significant history, came in for evaluation for reflux. But his main complaints really is chronic cough, hoarseness. He has occasional heartburn. He takes antacid as needed. That helps with the heartburn, but does not use any medications chronically. Has no dysphagia or odonophagia, no association between symptoms, any food and lifestyle triggers. So the question is, what would you do next? Would you put him on a PPI? Would you do a combination of PPI and H2 blockers? Maybe refer to an otolaryngologist, do a scope, do reflux studies, or some barium imaging studies. What do people think? PPI? Maybe? No? Referral to an ENT maybe? I see some heads nodding. Would you go straight into a scope or reflux testing? So a number of people would do that. So let's talk about what the diagnostic options for these patients. We often think about PPI trial just like typical reflux patients. So that's one option we talked about. There might be certain airway studies that can help us, laryngoscopy, bronchoscopy, depending on their presenting symptoms. Traditional esophageal testing, upper endoscopy, pH monitoring, pH impedance monitoring. There are more targeted testing for LPR, pharyngeal pH monitoring, maybe a combined esophageal and pharyngeal pH impedance study. And now there's some biochemical testing as well, like pepsin or bile acid in the saliva or BAL fluid. So one question we think about is that, what's the best approach in treating these patients' possible LPR with throat symptoms? There have been some study looking at the 5-year per patient cost of managing these patients. It's really high, over $13,000, and most of them are PPI driven. And there's also a lot of compliance issues with patients taking twice a day medications. A lot of times patients just kind of stay on the PPI and never came off. And one of the questions is, can we do objective testing more upfront and maybe reduce its cost and exposure to PPI? And this is actually a cost-effectiveness study that was done by one of my partners looking at empiric PPI regimen versus upfront reflux testing. What they found was that when they put them on these acid suppression regimen, the response rate is not terribly high. But when you look at the cost is actually quite high, the highest with the empiric acid suppression group and the lowest with the testing group, mainly because you're not keeping these patients on medications long term. And on top of that, the data for PPI in this group of patients is actually not that great. They've been very variable. In the meta-analysis, you see very marginal benefit of PPI in throat symptoms. So, whether or not there's value for that remains debated, although we do that quite often still. So, and there's another trial that just came out this year. It's actually a randomized placebo-controlled trial of over 300 patients, BID lansoprazole versus placebo, and they saw no significant difference in terms of their quality of life and symptom severity. So, as a lot of patients do, by the time they come see us, they already completed a trial PPI with very marginal change in their symptoms. The question is, what would you do next? Would you keep them on longer than 3 months of PPI? There have been some suggestions that maybe the throat symptoms would take longer to heal. Or would you then refer them to an ENT, do an endoscopy, do testing? I think we might do more than one of these probably simultaneously. So one question is, we'll often get these patients from ENT who has had a laryngoscopy, and the question is, do they, they tell us, we see signs of reflux. So what does that mean on the laryngoscopic findings? There are some findings that may suggest LPR or reflux-induced injury, but the correlation between symptoms and these findings are very poor. We know that there are many factors other than reflux that may contribute to these laryngeal nonspecific irritation. And actually, there was one study that found that up to 87% of healthy volunteers have at least one sign of these on their laryngoscopy. So it's very not useful. And I've seen patients getting sent over because they have some positive finding on laryngoscopy. We treat them, they have no more symptoms, but their ENT keeps scoping them and say, no, there's still signs of that, keep treating. So you should treat the symptoms, not the laryngoscopic finding. In fact, we don't really rely on it very much. So it may be useful to rule out other pathologies. I think if you were going to have an ENT do a laryngoscopy, that would be the main reason. Make sure there are no lesions, mass, or anything causing their symptoms, but not to diagnose LPR. So not surprisingly, these patients' laryngoscopy was unremarkable, except for some mild erythema, and you're considering further testing. What type of test would you do? I think that's the biggest question. Would you do a scope? Would that be useful? How about manometry? Would you do a pH monitoring, like a Bravo study? Would you do a pH impedance study? Would you consider those pharyngeal pH monitoring or biochemical testing? I see heads nodding as I go through them, so I think people have done probably a combination of this. First of all, endoscopy, just like with typical reflux, oftentimes have very low sensitivity and specificity, and specifically in this population. Most patients, you're probably not going to see esophagitis. I think the ones that you do will be the easy one to manage. How about pH monitoring? There have been some study that assess temporal association between acid reflux and symptoms and able to quantify the acid exposure. And there actually were some study that shows that it may predict anti-reflux therapy outcome even for these extraesophageal symptoms. The problem is that the sensitivity is still low, even in study where they added a proximal pH sensor. Partly because they can't identify weakly acidic or volume reflux that may also cause problem in the airway. What our pH impedance study, adding the impedance component where we can actually look at bolus reflux, regardless of the pH level, right? Does that add to it? So there are some studies that show that weakly acidic and non-acidic reflux may also play a role in some patients with chronic cough, mainly trying to associate their symptoms with reflux. And this specific study actually also showed that the cough-associated reflux episodes tend to be higher and they take longer to clear. And when they compare these episodes to one that are not associated with cough, there's no difference in their pH levels. So maybe pH impedance will be useful in identifying reflux in these patients. But the problem is that in further studies, these reflux burden on impedance pH do not always consistently correlate with symptom severity and response to therapy. And a lot of times you don't see pathologic reflux as we normally define them, and they often have normal study because of the acid exposure time or even total episode. So what does that mean? And sometimes diagnosis is even more challenging. You can't associate their symptoms. So if the symptoms are just hoarseness or sore throat, could it be related to reflux or even induced by reflux at all, even in the setting of hypersensitivity? The other one that we talked about is the pharyngeal pH monitoring, where you actually place a pH monitor in the back of the throat and try to detect pH changes. It have been suggested it might help. There's a different cutoff for this pH monitor with a different scoring system. But I can tell you that, like, with a lot of further study that's been done, it's been shown that it's not that great. When they combine this with a pH impedance episode, a lot of times when they see these changes in pH, there's actually no reflux going on in the esophagus. So there are a lot of things outside of actual reflux events that's causing these changes. It doesn't correlate really well with symptoms and also response to therapy. So it might not be terribly accurate either. So one of the newer catheter that came out, I think it was alluded to one of the questions earlier, is these LPR catheter, or these combined hypopharyngeal esophageal pH impedance catheter, where you actually, it's spaced a little bit differently, and you can actually place the pH sensor closer to the upper esophageal sphincter with impedance sensors kind of spanning that. It allows you to identify full column reflux coming all the way up to the pharynx if that happens. And it's been suggested so far with data that maybe more than one episode a day that goes all the way up to your pharynx is enough to diagnose LPR. Now, that's not really well validated. I think answering one of the questions earlier, when you see, let's say, 3 episodes, is it very abnormal? I think I would call that probably borderline, because in some other, when we look at some of our data, there are a lot of patients that can have up to 5 to 10 episodes with very minimal symptoms at all, and oftentimes they may not be related. So I think it's a useful catheter, but I think the normative cutoff needs to be better validated. And this is an example of what it looks like: the pharyngeal sensor, proximal esophageal sensor, distal esophageal sensor, and an episode going up. And this is actually a non-acidic reflux event that's going up to the pharynx. And there's been a couple studies looking at case series, picking out patients with a positive test on this combined catheter and did surgery on them. They actually had a very high success rate. About 90% of them reported improvement in symptoms, but obviously this is a non-controlled trial. It's just a case series, but maybe this will be a useful catheter. How do we compare it to traditional parameters on pH impedance? There's a study that we did looking at patients who have traditional parameters from a pH impedance, the AET, the total episode, compared to these pharynx events. And we found that actually distal parameters don't really have not a great sensitivity in diagnosing pharyngeal events. A lot of times because the number of events that are required to be considered abnormal in the pharynx is actually much lower. If you have not a lot of reflux, but every single episode is going up to your throat, that might be enough to cause symptoms, even though from the esophageal standpoint, that's considered a normal reflux burden. So that might be something to consider, and whether or not a catheter like this may actually help you detect more patients. How about comparing the symptoms? Can we predict based on symptoms alone? And this is another study, a couple studies that we did trying to see, well, can we just use symptoms to predict what happens with pharyngeal events? And it turns out that the sensitivity and specificity are low in terms of symptoms predicting the number of episodes of reflux going to the pharynx, whether you use a scoring system or just whether or not they have symptoms alone. So clinical symptoms alone may not be sufficient. And I'm just going to show this really quickly. We have found that using this catheter to detect pharyngeal events actually is able to predict and correlate with patients' symptom severity and quality of life as well. So maybe this is actually a better measures of how much reflux go to the airway. I'm not going to go into the details of this, but we now know a lot of advanced metrics on pitch impedance study, mainly baseline impedance might be helpful with reflux. And we did a study looking at whether or not this low baseline impedance can also predict pharyngeal reflux events. It seems like there's a correlation, maybe something that we can explore more in terms of utility in diagnosing LPR or airway reflux. How about manometry? We know that manometry is useful for reflux patients, meaning assessing dysmotility, assessing landmarks, maybe how you place a pH catheter, pre-op evaluation for anti-reflux surgery. But what about extraesophageal reflux symptoms? There have been some studies that have shown that certain findings might be more prevalent in patients with extraesophageal reflux and may predict worse outcome, like failed or weak swallows, large breaks, or any upper esophageal sphincter abnormalities. We did a study looking at LPR patients, or patients coming with laryngeal symptoms and who underwent manometry, and we found that the patients who have a lot of failed swallows tend to have more severe symptoms. Not so much the weak swallows, so maybe hypomotility is an issue with these patients. The reason this might be important is that maybe poor clearance of reflux is actually a big factor in these patients, not just how much is refluxing alone. And if we're thinking about doing surgery, wrapping them, creating more of a barrier, if clearance is an issue, you might actually make the issue worse. So understanding the motility may actually be important in this patient population. And we actually look at about almost 200 patients and just trying to see, well, what kind of motility pattern can we see? Up to 43% of them have some sort of abnormal finding on manometry. And most common of them, not surprisingly, is ineffective esophageal motility, but we also found esophageal gastric junctional outflow obstruction. We found other major peristaltic disorders, including achalasia and spasm. So that might be something we need to consider, and manometry may actually be important in these patients as well, including those without esophageal symptoms. Maybe other metrics will be important. We look at proximal esophagus because we're thinking about the airway, and we found that we look at over 100 patients who had manometry and this combined pharyngeal and esophageal pH impedance, and we try to look at whether the contractile function of the proximal esophagus correlate with reflux. And not surprisingly, the patients who have a lot of reflux going to the airway have weaker proximal esophageal contractility. So maybe that's another factor that's playing a role in causing this airway reflux. And maybe that also will help us think about how we treat them. If you have poor contractility, including the proximal esophagus, again, maybe wrapping them might not be a good idea. Maybe those reflux band that protects your upper esophageal sphincter may be a better option in treating these patients, even if they have a lot of reflux events. So that's something to consider as well. Maybe more work can be done, hopefully, to look at correlating with treatment outcome. We talk about pepsin, biochemical testing as a possibility. It's a proteolytic enzyme, mostly secreted in gastric chief cells, and it's been shown maybe play a role in damaging the epithelium related to GERD or LPR. And the question is this just a marker, or is it actually part of pathophysiology of LPR? If you see them in the saliva, trachea, other areas, it might suggest reflux. And there's actually a test looking at saliva pepsin level that's been commercially available, even in the US now, looking at pepsin in saliva to help detect extraesophageal reflux. It may be helpful. It has a decent positive predictive value and negative predictive value. Mainly if you do them, you have to make sure the patient collect them in the morning after they wake up. It may be a useful adjunct. I wouldn't use this as sort of the only test for reflux, but it might add to your diagnostic algorithm, especially if things are not clear. And as we talked about, there's a little limitation with this test too, because some studies show that it can't really differentiate patients and healthy controls really well in some prospective studies. So I think it should be a good adjunct test, but not a test on its own. There might be other possibility like bile acid, especially if you're doing a bronchoalveolar lavage. It might be, there'd be some study looking at detecting those in the identifying reflux. Obviously, that's something that hopefully there'll be more data on later. We talk about a lot, I've heard a lot about phenotyping. So can we phenotype these patients too? We talk about them in the typical reflux patients, about these extraesophageal patients. This study that just came out, we did with Reina actually in San Diego. We combined our patients and try to cluster them and see if we can find different clusters of patients depending on their characteristics. We were able to actually find 5 different phenotypes that may actually match with how we see these patients and help us inform our management algorithm. We see a group with very typical reflux features, with hiatal hernia, with a lot of reflux hypomotility. We see those with positive pepsin level, but very mild level of esophageal reflux, maybe mild GERD. There's some that had no evidence of LPR or GERD at all, and there's some that's more correlating with a reflux cough, where there's symptom association, but not a lot of reflux burden. And then in the mixed group of maybe some dysmotility that we're not so sure about. But maybe this can provide us with a framework in approaching these patients. And this is sort of like a proposed sort of framework. We think, well, based on these phenotyping, maybe we can approach patients this way. You know, if they have very typical reflux type symptoms, then it might be group A or B, and then we'll do reflux monitoring to further classify them, versus if they have no typical reflux symptoms, it might be closer to the last 3 groups. Then we can think about classifying them using different studies. So this is the framework we can think about. And if you look at this, and I'm going to show you one algorithm that more people are currently using, that I've been using in managing these patients, it's actually not that dissimilar, because we're still the first breakpoint is still whether or not they have esophageal symptoms or reflux. Very similar to what we propose with our phenotyping. And if you have esophageal symptoms, manage your esophageal symptoms. And if they're persistent airway symptoms, then repeat their studies, maybe consider other causes. If they don't have esophageal symptoms, right now, a lot of people do a trial PPI. I know it's questionable now. I think we're trying to move away from that and maybe do testing earlier on. And if they don't have reflux, then also consider other causes like airway hypersensitivity and other laryngeal causes. So I had a number of slides on lung disease, but I know I'm running out of time, so I'm going to stop there. But you know, we can employ a lot of these same diagnostic strategies for patients with lung diseases as well. So thank you.
Thank you, Walter. And we're going to move on and talk about ineffective esophageal motility. Walter brought up motor abnormalities in this context. We moved this motor disorder to the GERD discussion for that very reason. The presenter is going to be Elisa Coker. She's an assistant professor of surgery at Johns Hopkins. Unfortunately, she couldn't travel. Hopkins has a travel ban, so she's going to present virtually, and we'll have Phil Katz and Walter take the questions afterwards.
Good morning. I would like to thank our chairs for including me today. It's really an honor to be included amongst this panel, and I apologize that I couldn't be there in person. I very much would rather be so. I hope you're all enjoying the meeting and Nashville. Hopefully next year we're in a better position. I can join everybody. So I've been tasked today to speak about ineffective esophageal motility. These are my disclosures. So some of the things I'd like to cover today, I want to review obviously the Chicago classifications of IEM, understand the impact of IEM on surgical management of GERD, and review some of the surgical options and how IEM may influence that decision. So let's jump into it with a case. So this patient is a 59-year-old male. He was referred to me for consideration of anti-reflux surgery, given he had Barrett's esophagus despite maximal medical therapy. His GERD symptoms were actually well controlled on medication, and he reported only occasional dysphagia, although he was a poor historian. And he has undergone multiple cryoablations for treatment of his Barrett's. You can see he's not the healthiest patient, some high blood pressure, high cholesterol. He does have a cardiomyopathy with an EF of 35%. He had an AICD in place. And had chronic AFib on Pradaxa and a history of stroke. So this is his swallow study. I do get routine imaging on all my foregut patients, preferentially a cine, but some insurances can cover only an upper GI. So I'll make do with that. This patient has a small sliding hiatal hernia. A cine is more likely to allow you to see reflux on the image itself, but a good radiologist will comment on what they saw during the actual exam if all you have is an upper GI. So the read on this study, for example, commented on occasional GERD observed by the examiner. There was no delay of transit into the stomach. His EGD, you can see some of the images here. He had a 4-centimeter sliding hiatal hernia and LA Class C esophagitis, as well as evidence of residual Barrett's. On his pathology, it was consistent with Barrett mucosa of the distinctive type with reactive epithelial changes and no dysplasia. Our current case patient did not have a pH study. I would not ask for a pH study in patients with LA Class C or D, esophagitis, or Barrett's. I wanted to include a pH study, however, as I wanted to at least demonstrate how I approach these as a surgeon. First, I always prefer a patient off of therapy. If they come to me and they have a normal study on therapy, I have to reorder them because I can't offer anti-reflux surgery off symptoms alone. If the study is normal and they are on therapy, all I can say is to the patient, maybe you don't have reflux, or maybe your reflux is well controlled with medication. If a patient is just worried about acid exposure, I'm a big fan of ordering the study as 2 days off and 2 days on. So you have 2 days to document the presence of reflux and 2 days to understand how well their meds control it. I find this useful for patients trying to decide if they want to undergo anti-reflux surgery. This particular patient had a Bravo pH study performed off therapy. You can see this was a 4-day study, but the capsule fell off on day 3, as indicated by the drop here. So only the first 2 days were included in analysis. The 2 numbers I look for immediately on these studies is the total acid exposure time, which was abnormal at 9.5%, and the Demeester score, which was 33 in this patient. I always look at the symptom correlation as well, which was poor in this patient. This is information I use primarily for informed consent. If a patient has objective reflux, that is an indication for a procedure, no matter what. But if they demonstrate poor symptom correlation, particularly for classic symptoms of GERD, they should be informed they may have persistent symptoms despite anti-reflux surgery. Moving on to manometry. If nothing else, I hope you walk away from this session understanding the value in it. I encourage it in all my patients, and I will not perform a full wrap without one. You never know what you will find, and as a surgeon, it can affect whether I offer any surgery at all or change the surgery that I recommend. Back to our specific patient, this is his high-res manometry. 5 of his swallows are pictured here, and you can see right away that the topography of his swallows are not great. Here is the composite. This is what I actually look at. There are surgeons that are experts at manometry that perform and read their own manometry. I'm not one of them. And I say this to stress that even without being an expert, you can get a lot out of understanding the basics of manometry. I think too many physicians, surgeons in particular, just jump to the impression, but I would encourage anyone to really look at the numbers. There are rare occasions when I disagree with the impressions provided, not usually from my own institution, but from outside, or at least it causes me to seek out more information. For this patient, you can see he has 90% failed swallows. His DCI is only 222. but he has a normal IRP. This is one that was read by Dr. Stein, who will be speaking to you shortly. Overall impression was severe IEM. IEM. It's the most common abnormality observed in routine manometry with a prevalence of 20 to 30%, and this is even higher in patients with symptoms of dysphagia. It is the primary motor dysfunction in many of our GERD patients, and there's an even higher incidence in our patients with erosive esophagitis and Barrett's. There are, of course, other etiologies or associations with IEM. To name a few, this includes neuropathy from alcoholism or diabetes, amyloidosis or rheumatic disease, those with chronic cough, those with injury to their esophagus, such as having previous ESD, and more. So let's define ineffective esophageal motility. Chicago classification version 4 defines this as a normal median IRP and greater than 70% ineffective swallows or greater than 50% failed peristalsis. An ineffective swallow includes all of the following. It's either weak with DCI between 100 and 450, or it fails altogether with a DCI under 100, or fragmented. You may be wondering how the most recent Chicago classification updates vary from previous versions in regards to IEM. In short, it's much more stringent than previous version, in which only greater than 50% of swallows needed to be ineffective, not the greater than 70% I just defined. This newer version also encompasses fragmented swallows, which was previously its own motility disorder, minor motility disorder. Probably not surprisingly then, I can tell you as a surgeon who orders many manometries, I have seen a huge decrease in the number of patients diagnosed with IEM, given that the classification is more stringent now. Prior to having high resolution manometry, this was defined as having 30% or more of liquid swallows that had an amplitude under 30 in the distal esophagus. While not required for the diagnosis of IEM, supportive evidence of it includes poor bolus transit on impedance or barioesophagram and lack of contraction reserve on multiple repetitive swallows. These are both also additional tests that may drive your decision-making in regards to what a patient can tolerate if they're considering anti-reflux surgery. So why would we need these? Why not assume that a manometric diagnosis of IEM will be clinically significant? There are studies demonstrating that despite that diagnosis, bolus transit may be preserved in many cases. This study, for example, demonstrated that in 70 patients with a manometric diagnosis of IEM, 48% of liquid and 38% of viscous swallows showed complete bolus transit. Almost a third of all patients had normal bolus transit for both liquid and viscous swallows, making the argument that effectiveness should really be determined with adjunctive tests of esophageal function. I should say, however, that these studies were based off older, less stringent definitions of IEM, so we would presume that there would be a higher number of clinically significant diagnoses within the now smaller group of patients that meet the CC4 criteria. The multiple rapid swallows is one test that may help you determine clinical relevance that we mentioned. This is performed by giving 5 2-milliliter swallows separated by 2 to 3 second intervals. This is going to inhibit the esophageal body, but will be followed by a contraction of increased amplitude. So then you compare this contraction to the average DCI of the 10 test swallow to get a DCI ratio. This should be greater than 1, and that's what we see in 78% of healthy individuals. Only 38% of patients with IEM are able to generate normal contractions after multiple rapid swallows. From a surgeon's perspective, if a patient has peristaltic reserve on MRS, I may feel better that they will be able to tolerate a wrap, even a full wrap. Barium swallow is another supportive esophageal function test. We looked at this earlier. We know that contraction amplitudes required to empty a bolus will vary with the consistency of that bolus. Thus, a challenge with only liquids may not be enough to identify clinically relevant IEM. Thus, an alternative substance that is both of solid consistency and of large enough size may provide a more accurate challenge. So I would make an argument for a marshmallow test. You give a standard marshmallow cut to 1/3 to 1/2 of its size, coat it in barium. Studies have demonstrated that this can induce dysphagia when a stricture or abnormal motility is present. Because our patient has severe IEM, I also want to give you an example of a patient with mild IEM. Here's another one of my GERD patients. Her topography looks much better with some propagation in higher pressure areas, comparatively anyway. She has a normal IRP. She had 10% failed swallows, 30% weak, 40% ineffective, and 30% fragmented. So the overall impression for her was mild IEM. So once a diagnosis of IEM is made, how does this affect our surgical decision making? Well, it's complex, right? We know that there's evidence to support that esophageal body contraction improves following anti-reflux surgery, but we also know that distal esophageal obstruction, which is what I create, can also improve body contraction. So whether it's from improved acid control, which allows healing of esophagitis, or from the distal obstruction, improving motility, one outcome, the hoped for outcome, is that IEM actually improves. Another acceptable outcome would be that the patient's underlying motility disorder persists, but at least doesn't get worse. And then, of course, the feared outcome would be that they present with dysphagia, we perform anti-reflux surgery, and their motility actually worsens as they aren't able to generate enough force to overcome the wrap easily. So if I have a patient that presents with dysphagia, I have to tell them it could get better, it could stay unchanged, or it could potentially get worse. Not always that useful, but it's part of the informed consent process. So whether a patient wants to move forward often depends on what their indication is. In a patient with Barrett's and severe esophagitis, my inclination would be for a full wrap or a Nissen fundoplication. This is a 360-degree posterior wrap. The result is a beautiful, I call it Neo Hill grade 1 valve with a nice ridge or lip around your scope on retroflex. The concern in this patient, of course, is will he have enough force in his swallow to overcome that distal obstruction given his severe IEM? A full wrap is not a contraindication in IEM. There are several studies that have demonstrated good outcomes with full wraps in the IEM patient population. This study compared the results of a full wrap in 35 patients with IEM to 82 with normal motility. They looked at their results 1 year after surgery and who reported good or excellent outcome. 95% of the normal motility group did that, and 91% of the IEM group did. So they were still happy with the results. None of the IEM group required dilation. Both groups had improvement in dysphagia. In the IEM group, 11% had new onset dysphagia. Of those with pre-op dysphagia, 40% reported this resolved or improved, 9% had no change, and 3% had worsening of their dysphagia. Ultimately, the authors concluded that patients with IEM fare equally well from lap Nissen as those with normal motility. Taking it a step further, beyond just surveys and subjective measures, this study compared the pre and post fundoplication manometries in patients with preoperative IEM and GERD. They had 19 patients overall. 79% of them underwent a Nissen, 21% a partial fundoplication. What they found was that the mean distal peristaltic amplitude increased by 47% overall. When you looked at that post-fundoplication motility, it was normal in 74% of patients. And in those that it was abnormal, 26%, 10.5% had improved motility still compared to their baseline, 10.5% were unchanged, and 5% were worse. But interesting enough, that was in a patient that had a toupee. Despite this evidence, many will opt for a partial wrap in the setting of IEM. In the setting of a hiatal hernia repair, where you are already performing a posterior dissection, most would opt for a toupee. This is a partial posterior wrap, generally anywhere from 180 to 270 degrees. A door fundoplication or an anterior partial wrap is the other most common partial wrap you will encounter. I want to share a video on how a toupee is performed. One, because what is a presentation without at least one cool video? And two, because I know there are many of my GI colleagues in the audience who may not have had the opportunity to see what this looks like. So here you can see we're pulling the fundus posteriorly. We do what we call a shoe shine maneuver here. We're doing this to make sure that it's not under undue tension, that posterior portion pulled under isn't just flipping back quickly, and to make sure it's not twisted. And then we use a permanent or long-term absorbable suture to secure the stomach to the esophagus, plus or minus a crural pexy, so tacking it to the crura like I'm doing here. I generally do this for my uppermost stitch. And then you'll see that I'm going to put 2 more stitches below this, and then we repeat it on the other side. This is sped up and obviously edited out just to not bore you to death. But the end result is to create these lips on both sides. I think, in talking to my GI colleagues, one of the things I've had to express to them, it's important for you to get is there's more art to this than you might think. It's not like we're measuring exactly in the OR, whether it's a 270 versus the 180 degree wrap. Often we're performing the wrap and looking at it subjectively, both in the abdomen and with the laparoscope and in the retroflex view endoscopically. Not uncommonly, I may perform endoscopy and decide based off the appearance of the wrap that I need to add an extra stitch. And that's kind of the end result that you hope for there. I always end my case with endoscopy, so I can ensure one, total reduction of any hiatal hernia present, and then evaluate that wrap. And what you want to see is a nice ridge abutting the scope, that neo-Hill grade 1 valve. Okay, so we've seen evidence that a full or partial wrap is generally well tolerated. So how do I make this decision? These are the factors that I'm weighing. 1, how bad is their disease, both in terms of GERD and their IEM? Can I reasonably suspect that better acid control will improve their IEM? 2, do they have a primary complaint of dysphagia? These patients make me nervous, and I'm more likely to opt for a partial wrap. 3, what is the tolerance of dysphagia? This includes my tolerance and my patient's tolerance. So if I have a high anxiety patient that will be calling me stressed out, and every time they feel the slightest difficulty swallowing, I'm probably not going to gamble on a full wrap. Even if it's only that 5% that gets worse, those 5% will take up 95% of your time. I would also suggest that if you don't have a multidisciplinary meeting, you form one. We have both a heartburn conference and a motility conference with a lot of overlap, obviously, between them, where we discuss difficult cases. Having worked with my GI colleagues for several years, I can generally predict fairly well what the recommendation might be, but as I often have to remind my GI colleagues, anti-reflux surgery is a highly litigated field, and I do like to just document sometimes that it was discussed and that consensus was reached. So the final decision I made for this particular patient, after discussion with our multi-D team and the patient, was to perform a hiatal hernia repair with a toupee. His severe IEM had me concerned that he would not tolerate a full wrap. I'd love to tell you that was the end of the story and he did well, but I think it's important to see these complex cases, so I'll tell you what really happened. He had a small recurrence of his hernia and recurrent esophagitis despite an intact wrap and maximum medical therapy. Out of concern that his Barrett's might become dysplastic, we determined in multi-D meeting and with extensive counseling of the patient that he should be revised to a full wrap. This did resolve his esophagitis, but as expected and as he was counseled, he does have some dysphagia to solids now, so worse than what he had pre-op. This is mostly controlled with dietary restriction. I think I always have to tell my residents and colleagues that unfortunately, some patients have to learn that swallowing is not a guarantee in life. Conclusions that I would like you to take away from today. A thorough workup is critical when deciding if a patient is a candidate for anti-reflux surgery. The latest Chicago classification criteria are more stringent for IEM. IEM may not be clinically significant. The patients may not be coming to you complaining of dysphagia. And a fundoplication, full or partial, is not contraindicated in IEM. And finally, informed consent is critical when considering surgical intervention. With that, thank you so much for your time. I hope this was useful.
Thank you so much. And now I'd like to invite Phil and Walter up on stage, and we'll do a quick Q&A. If anybody has any questions, please come up to the mics.
So again, Patrick Chasson, I really enjoyed your talk, Walter, about LPR and extraesophageal manifestations. I was interested that you didn't refer to Blair Job's work looking at the CEP70 pepsin ratio as a more specific determination biopsies in the oropharynx for LPR and GERD.
There have been more data on, pepsin level, especially either from a salivary sample or getting biopsies and getting staining. I think that all those are still going to be mostly adjunctive in terms of testing at this point. We may have a better or more improved way of more consistently validating those and how they correlate with treatment outcome. But I think so far, at this point, I think those should be adjunctive tests compared, in addition to the other.
Thank you.
Casey Graybill. Just to complicate the conversation a little bit about LPR, there are a couple of things that warrant consideration in practice and maybe warrant some conversation maybe at our next meeting. The first is cricopharyngeal dysfunction, which might present obstructing the, obviously end stages as anchors, but probably a lot of reflux patients with some degree of spasm that induces a globus sensation and, might be contributing to some of their symptoms. And the other is inlet patch, which never really gets any airtime. In our practice, we've had several patients, both post-fundoplication and untreated, who have presented with LPR-type symptoms, including some with negative Bravo and a positive proximal channel on a 2-channel pH study, as Don Castell published, I think, about 2.5 decades ago, that profile. So those, whether you believe that's an acquired lesion or not, that's something that produces mucus. We've seen it produce local esophagitis and other symptoms and done several ablations for it. So it's another rare, uncommon issue, but something worth looking at.
Yeah, there have been about 2 small studies looking at ablation of gastric inlet patches with these patients with throat symptoms, mostly case series, that patients actually did better with them. So that's certainly one of the things when we do endoscopy in these patients I always tell the fellows to carefully withdraw and make sure that we actually look at the proximal esophagus as well to look for these. With regards to upper esophageal sphincter function, also potential diverticulum, I almost always get a video swallow study in these patients too to make sure that there are no other abnormalities outside of reflux that could be causing their symptoms. So that's always usually part of the algorithm as well. So,
thank you.
I commend you, Walter, for talking about moving away from the algorithm that uses a PPI trial early. It brings into play all of these other things without a very long course, and hopefully we can sort it out.
Yes.
Yeah, hey, I guess no one's over there. Kevin Gillian, surgery as well, and been doing my own motility for 20-something years, and so I've been got a pile of ENTs that send me lots of these kinds of patients, some good, some not so good. All of them have had some sort of sinus surgery, or 4 or 5 of them that didn't work, and then they come to me to fix it. Pattern recognition. 2 things I've noticed over the years. A lot of these people, when you do pH testing on them, they're symptomatic all day long. They're coughing at work, they're clearing their throat, but they're refluxing at night. Okay, and so it's an interesting pattern. If you look, it may not show overall elevated Demeester score, but then you'll see like maybe a 3 or 4% exposure at night, some long episodes at night that they don't really wake up for, and they have normal pH scores during the day, probably because they're taking their PPIs the right way out. But just a pattern. You know, they get irritated at night, they pay for it during the day with their jobs, clearing their throat, talking on the phone. And then Pepsin, you know, I've been using that for more than a decade. Even before there were assays in the U.S., I had piles of this stuff in my office that we'd have to send to the U.K. through FedEx to get the testing done. I found it to be helpful, but I use it as a tiebreaker. I don't use it as a diagnostic tool. I tell the patient there's no study that tells me this is diagnostic for LPR. It's just suggestive. And if we're kind of sitting on the fence about what we want to do, I say, let's try this. If we come back with 3 out of 3 that are screaming high, positive, then I'm a little more positive that we might have a good outcome. But usually when we're at this level, we're not dealing with real pathology in terms of something dangerous with these people. We're dealing with quality of life. So they need to make the decision that it's worth it to them. And this is just an extra piece of evidence, I think, to help guide them.
Yeah, absolutely. I think one thing about the Pepsin, currently for the ones available in the U.S., you basically, if you patients get the kit, they collect the samples, you actually send it into the company to get them analyzed. They do some, you can arrange for actually equipment and buy the equipment actually to analysis in your office. I don't know how cost effective it would be, but if you're actually going outside the company, maybe asking other labs to do Pepsin analysis, make sure that they're doing the right subtypes of Pepsin, because Pepsin A is the one that is what we want to measure, is exclusive in the stomach. Pepsin C actually can be present in pneumocytes as well. So if you see Pepsin, if they're testing for both and it's actually from Pepsin C, it might not actually be coming from the stomach. So the subtyping of Pepsin actually is important if you're going to ask your lab to do it outside the company.
And let me ask the final question to Phil. The patient that was mentioned with the nighttime acid exposure continuing despite PPI, do you ever use baclofen? And if so, what do you think its role might be?
Excuse me. I don't use it much. Potential is hard to refute because of the physiology, as you know. It does reduce reflux episodes, and it probably reduces TLESRs. And the little data actually shows short-term efficacy. If I use it, I still like to start at 5 milligrams at a time and slowly go from there to see how people tolerate it. If I'm still in the medical arm, I'd use an H2 blocker at night, as I suspect you would first. But honestly, I just don't use it much. But that would be the way I use it if I did.
Wonderful. Thank you so much. And we're going to move on to the final segment. We're going to talk about some of these adjunctive measures. I'm going to change up the order just a little bit, and we're going to start with a video from Megan Reel, who's a clinical psychologist from the University of Michigan, and she's going to talk about some of these adjunctive measures that we use for esophageal symptoms.
Hi, I'm Dr. Megan Reel, and I'm a clinical health psychologist specializing in psychogastroenterology at the University of Michigan. Thank you to the planning committee for asking me to give a brief review of brain-gut treatments and psychogastroenterology for this conference. So I'll begin briefly with just what is psychogastroenterology. And what's most important is that it applies evidence-based psychological principles and interventions to aid patients in the management of their digestive condition. And I'm going to focus treatments today on functional or disorders of gut-brain interaction diagnoses, but many of these psychogastroenterology interventions can be applied to organic diseases in the spectrum of gastroenterology patients as well. But we really focus our treatments on applying them within the context of a collaborative, integrative team. We begin with appropriate referrals. And as I said, patients that experience disorders of gut-brain interaction, the interventions that we apply have the most research, and it's quite robust research supporting the application of these interventions with patients with IBS, functional dyspepsia, various aspects of heartburn or for the PPI non-responder, globus, and functional dysphagia. And as I said, we also apply these interventions for organic diseases as well. While this is a very long list, I always like to share that the psychogastroenterology treatments that we use are most beneficial for patients that are seeking out treatment for their GI condition. So if they have more predominant psychiatric problems, those patients should first be referred to a general mental health provider or perhaps a mental health provider that specializes in the psychiatric condition that they are struggling with. This is most important to highlight for patients that have severe psychiatric conditions, getting their mood stable with medication management or potentially even an inpatient hospitalization is something that takes precedence. And also if someone has an eating disorder, we would want that patient working with a specialist. So we know that there's a lot of complexity in a functional bowel or a functional esophageal diagnosis. These are just a few of the aspects of that diagnosis. So poor sleep, poor coping strategies, the role of visceral hypersensitivity, and the psychological phenomenon of symptom hypervigilance, as well as early childhood stressors, can all have an impact on this functional diagnosis. Therefore, treatment modalities are often multifactorial as well. So when we're making a referral for a patient to a GI psychologist or a mental health provider that specializes in psychogastroenterology, you first, as a gastroenterologist, want to confidently deliver the patient's diagnosis, providing them with reassurance, as well as making sure that a full workup has been completed and that no further testing is needed. This helps to instill confidence in the treatment plan. And when we have confidence in the diagnosis and the treatment plan, it really provides the patient with hope. When it comes to the most evidence-based behavioral interventions, we're commonly applying CBT or cognitive behavioral therapy in the context of the patient's gastroenterology issue. And oftentimes we're also using some form of gut-directed hypnosis. And as you can see here, both of these interventions and types of therapy have level 1 support in terms of research. Emerging areas of research for patients with functional or disorders of gut-brain interaction diagnoses are mindfulness-based stress reduction, as well as psychodynamic interpersonal psychotherapy. We see this used a little bit less in clinical practice at this particular time, but it's worth noting. So as we can see, when we think about brain-gut and gut-to-brain interventions, the strong connection gives us different aspects of the patient's symptom presentation, as well as their kind of psychological principles, such as pain catastrophizing or the anxiety related to symptoms. And therefore, we can see how the evidence kind of addresses these aspects of dysregulation or symptomology for this patient. So when it comes to cognitive behavioral therapy, as I said, there's robust research supporting the use, and it's commonly applied by GI psychologists. And I think what's most exciting for patients is that we have research that supports that delivering cognitive behavioral therapy via teletherapy services is just as effective. So patients can receive these interventions from the comfort of their own home, which in clinical practice I've found has reduced burden and access to care problems for patients. And I really believe that we will continue to be delivering our interventions via teletherapy moving forward. So knowing that CBT and gut-directed hypnosis are effective is important and helpful for providers when they're making these referrals. When it comes to gut-directed hypnosis, it too is evidence-based and has very strong support for patients with IBS, but oftentimes we are applying different protocols for patients that have inflammatory bowel disease as well as esophageal conditions. It's very important to recognize that it will be up to the GI psychologist to create a treatment plan for the patient. So when making a referral, make sure that you're making the referral stating that the patient will initially have a consultation with the psychologist or mental health provider, and then together they will come up with the appropriate treatment, because not every patient is the ideal patient for hypnosis. This treatment tends to be about a 7-session protocol. And as we can see, the number needed to treat is very strong at a 2. Finally, I just want to make mention of mindfulness and relaxation, and that they are not the same. So mindfulness-based stress reduction teaches patients a variety of skills that really are focused on helping the patient to manage discomfort. Whereas relaxation training, such as teaching a patient diaphragmatic breathing or different muscle relaxation, is just one aspect of another skill that they're learning to help decrease physiological arousal. So I've included a link to a diaphragmatic breathing demonstration that you can use with your patients, perhaps as you recognize that you think they would benefit perhaps from behavioral interventions, and it can serve as a nice introduction. So in conclusion, patients and providers certainly benefit from this integrative GI model. And oftentimes patients are very open to working with a GI psychologist, particularly when a patient is looking for non-pharmaceutical opportunities. Understanding appropriate referrals will help to optimize the patient's ability to receive the right care, as well as create realistic expectations. And as I mentioned, virtual care is effective, improves access, and I've also seen that it's helped patients to complete their treatment. And also, as I've mentioned, allow the GI psychologist to determine the appropriate treatment plan for each patient. And then they'll reach back out to you to discuss what the patient will be undergoing for their treatment and for ongoing collaboration. Thank you very much for allowing me to give you this brief overview of psychogastroenterology and brain gut psychotherapies, and I'm happy to connect with you at any time. Have a great day.
Thank you. And now we're going to have a discussion of some of the disorders that can benefit from this kind of therapy. So functional esophageal disorders, that talk will be given by Ellen Stein. Ellen is an associate professor of medicine. She used to be at Hopkins, but she's now moved over to Rutgers. And so she's going to talk to us on functional esophageal disorders.
Good morning. Hi, I'm Ellen Stein. I'm an associate professor at Rutgers Robert Wood Johnson Medical School, and I'm the director of the Motility Center in New Brunswick, New Jersey. Today I'll be talking about the functional esophageal disorders, and I'll be focusing on a case with chest pain as the main symptom, and I hope this is helpful for you today. So the patient presented to me a few weeks ago. She was a 34-year-old woman who had daily burning chest pain. It was experienced in the mid-chest. It felt worse with spicy foods, and she had been to the ER on several occasions for her symptoms. Negative troponins were found. The EKG and echo were normal, and she does not report any exertional pain symptoms, but she does have the pain all of the time. So when she is doing her daily activities, she's having the pain. She can climb a flight of stairs. Her only cardiac risk factor is that she had preeclampsia in her pregnancy, but there were no other cardiac risk factors. She has no history of illicit drug use, and she only has a personal medical history of mild anxiety disorder with some panic. At an outside hospital, after an emergency room stay, a physician performed an endoscopy. Esophageal biopsies were taken in appropriate number throughout the esophageal lumen and gastric lumen, and all the biopsies were determined to be normal, and there was no frank LA grade A, B, C, or D esophagitis. She was given omeprazole 20 milligrams, which she reports taking daily without fail, and sometimes she takes Tums to try to get rid of her symptoms. She's been on the PPI therapy now for 2 months, with some relief, but still she's experiencing daily bothersome symptoms. and occasionally the pain gets worse and she really gets concerned and reports to the ER. When we inquired further, she said she does take her medicine daily, but she takes it after breakfast. When we asked a little bit more about her life experience, she did say that she was very stressed during her pandemic, trying to care for a young child. She denied any abuse or trauma, but mainly the symptom of pain was bothersome and on her mind day and night, really disrupting her life. On physical exam, she was hyperventilating slightly because she was very anxious and she was just mildly overweight, but otherwise there was a normal physical exam. So testing was performed. She was reluctant, but then we were able to convince her that a manometry would provide some benefit. And I was actually called into the room while she was getting the procedure performed because she began to panic as the catheter was placed. Her typical chest pain was reproduced with the passage of and the presence of the catheter. Her shoulders tensed up. She could barely tolerate the upright swallows, and she wanted to terminate the exam early. She was crying, and every time she tried to swallow, she would have triple swallow attempts, and then that would lead to a failed swallow effort on the manometry. So I gently kind of guided her into a better place using some soft tones, some verbal guidance, and some imagery. I coached her to relax her shoulders, to close her eyes, to take some slow, deep breaths, to think of any place other than the manometry lab. And we just sat there together in 2 minutes of silence while she was doing some deep breathing exercises. After that, when she opened her eyes, she was able to complete and tolerate the examination. The catheter was then removed, but her pain discomfort was still present, not as intense as it was with the catheter in. She had 7 of 10 normal swallows, 1 swallow with a DCI greater than 8,000, and 2 swallows with mildly weak peristalsis, DCI less than 450, and some large fragmentation and breaks in the peristaltic wave, but this is still normal by the Chicago 4 classification. We performed an off-therapy Bravo, and it was tough for her to keep the Bravo in. She experienced discomfort with the Bravo placement, and she was aware of its presence. But overall, she only had 2.5% acid reflux exposure on 3 of the 4 days with normal exposure, and 1 of the 4 days with equivocal exposure. No symptom correlation was noted specifically because she was experiencing pain consistently and it didn't spike at any particular time during the exam. Now, when we think about patients who have this type of atypical chest pain and we want to kind of do an evaluation, there was a great article by Ronnie Fass and his colleagues looking at functional chest pain in the era of Rome 4. If you start over on the left, chest pain as a symptom must have cardiac causes excluded. After that, an empirical PPI test, would be done to make sure that NERD or GERD were treated as a cause of the non-cardiac chest pain. Endoscopies with biopsies can be performed, and if there was a mucosal abnormality that was contributing, you can focus your therapy there. And then checking for reflux with off-therapy testing to see if a PPI long-term is warranted in this patient. If you did detect acid reflux that was non-erosive, then non-erosive GERD would be your treatment strategy. And finally, the esophageal manometry helps to identify any major esophageal motor disorders. If you did notice a positive symptom association, then that would indicate reflux hypersensitivity. And in the case with our patient, you could argue she sort of has a negative symptom association with her reflux, and that puts her in the category of functional chest pain. Now, when we think about each of these tests, the PPI tests were ruling out GERD or erosive reflux disease. It's a relatively low-cost test if you taper the drug, meaning if you don't do lifelong therapy, but the dose and the duration matter. For an endoscopy, you could argue that in the new algorithms, EndoFlip may be indicated as a rough guide to whether or not a manometry will be of any yield, but that's not currently in the guidelines. So just endoscopy with biopsies would rule out GERD or eosinophilic esophagitis. And any alarm symptoms always deserve evaluation: weight loss, vomiting blood, or iron deficiency anemia. The negatives of an endoscopy is that sedation will be needed, and it may be low yield without alarm symptoms present. For reflux testing, I prefer off therapy in this population if they can tolerate it. And we try to work our way to get to that point, because you want to know at baseline how much reflux they have and whether that should be your true line of treatment. This can be a costly method, it can be invasive, and in patients with hypersensitivity, placing a catheter or placing a pH probe can stimulate their hypersensitivity, and they can be very symptomatic during testing. Manometry, as I said earlier, rules out a major motility dysfunction. It's best to identify motor dysfunction. And an esophagram can be helpful, but the manometry is really the gold standard. For patients like this, it can be very uncomfortable, invasive, relatively costly, in considering that it's a test that needs to be done and the patient needs to take time off from work to get it done. Now, my plan for this patient was to optimize the timing of her PPI therapy, moving the dose to a full dose PPI before breakfast to try to get control of any residual reflux that might be triggering her symptoms. And that would be done for 6 months. And then we would try to optimize her lifestyle measures so that her reflux was reduced overall. We counseled her on exercising and walking daily and trying to aim to lose those 5 or 10 pounds that she may have gained, which could contribute to the development of reflux, whereas she may not have had it before the weight gain. She had a therapist that she was already working with on her anxiety. So we asked her to reconnect with her therapist. She had lost touch during the pandemic. And I specifically asked her to focus on both her anxiety and to talk about the role of cognitive behavioral therapy on reducing her symptoms and her hypervigilance to her symptoms, as this would help improve her outcome. And she acknowledged that her anxiety over the symptoms made it much, much worse. We definitely walked her through what her testing results were, and I'll talk about that more in a moment. And then I asked, is she ready to consider a neuromodulator to help decrease her sensitivity to discomfort? As I explained it to patients, I said, there is some level of irritation or irritability of her nerves to the usual physiologic happenings in her esophagus, and that's contributing. So she's experiencing her usual physiologic activity as discomfort. And she was open to considering this type of medical management, especially working with her therapist and thinking about her anxiety in general. She had previously stopped her medication that she had taken for a long time. So for me, patients respond best when you team up with them. And I think this is a critical feature of functional disease patients. They have real and palpable symptoms. They're fearing what the unknown is. What are they missing? So when I verbally walk each patient through what's been ruled in and out, discuss the warning signs of what could be, we then talk about how CBT and neuromodulators will decrease their symptoms, but how we'll partner and pair together to work overtime to find relief of symptoms. So for her, I explained how her biopsies had excluded eosinophilic esophagitis, Barrett's, inlet patch, hernia, and esophagitis. We talked about the reflux testing showing that her reflux, if it's present at all, is mild at best. It's not going to cause long-term harm if we manage it. The endoscopy excluded any type of twist or hernia or another anatomic cause, so we're not missing something. And her previous cardiac evaluations during her emergency visits did not show any active cardiac pathology, and her healthy exercise tolerance was something that reassured me and should reassure her. If she could walk a block or climb a flight of stairs without getting short of breath, that's a sign her heart's okay. We talked about how anxiety increases the chances of her becoming hypervigilant and hypersensitized, or perseverating on her discomfort, because that can be a trigger for her anxiety if that's something that she worries about. I specifically and always state that there is no current evidence of cancer, because that's something that's in the back of people's minds. We talked about the features of cancer usually would be weight loss, some endoscopic evidence of malignancy, or a family history of concern, and I take a detailed family history, and for her, there were no family members with a history of early cancers. So we, again, talked about monitoring her symptoms over time and finding relief. And she actually went from crying to smiling. And so at the end of the visit, she felt like there was some hope for her, and that was very rewarding. So in terms of medical management, what I tell patients are drugs are good. They are very good for symptom improvement. The drugs that have the greatest improvement and benefit for patients like her are neuromodulators. I also say narcotics are bad. They are bad for long-term symptom improvement. Over time, they can amplify pain sensitivity and cause negative side effects like drowsiness, respiratory depression, constipation, or addiction. And I do not provide narcotics to patients with functional disorders. I taper anyone who has been started on them, because narcotics do not address the underlying cause of pain and over time will not improve their pain symptoms. And people respond well when you explain it in this way, and they'll even acknowledge that the narcotics are not helping, and over time their pain has either consistently been present or even gotten worse. This is a slide from Doug Drossman's seminal article on central neuromodulators. And you can see functional chest pain, globus, and hypervigilance all have a similar treatment strategy, where functional chest pain has some greater evidence for trazodone and venlafaxine, but also SSRIs and TCAs. Globus has a treatment strategy of SSRIs in terms of studies. For patients with any element of hypervigilance, getting control of that anxiety is important with an SSRI and SNRI, or even short-term clonazepam, although I try very much so to limit the use of benzodiazepines in this population unless there's an element of spasm that deserves co-treatment. So what do you do with your doses? Well, for most of the patients, tricyclics tend to be a standby, and it's important that you get to a dose that's effective, because at lower doses, you get all of the psychomotor effects of the tricyclics, the constipation, but you don't get all of the benefits. And at higher doses, you just are outside of the range. And again, you'll get all of the side effects, but not all of the benefits. So you want to start at week 1 at a 25 milligram dose, week 2, 50 milligrams, and then get up into the 75 to 150 milligram range. You can do dosing by level. There are tricyclic levels to check for nortriptyline to make sure you're within the zone. But in general, getting up to an effective dose is important. And you need to explain this to the patient before you start the medication, the timing. Usually this can be done over the phone or even by giving the patient instructions about weeks 1 and 2, and then they report back how they're doing. If you're thinking of an SNRI, the most commonly recommended would be duloxetine. And again, you're going to rapidly escalate the dose to an effective zone. A lot of gastroenterologists can be afraid to do this, but really getting people into the effective zone will get them the relief that they deserve. So if you think about atypical chest pain and how much it's going to respond to these neuromodulators, there's a response nearly half of the time. And so that's something to be honest about with the patients. Between 50 to 70% of patients are going to experience symptom improvement and some symptom relief. You might need to combine this medication, whichever you choose first, with another medication to get complete relief. But often once you start to turn down the symptoms and show them that they can have some control over their symptoms, they may not even need to go on and to increase the medications. Just knowing that their pain can be relieved is sometimes something very effective. And working on the other side with cognitive behavioral therapy and management of their anxiety disorder can often bring down their pain levels to a very manageable zone. I don't promise no pain. I promise that their pain will be manageable. And I also ask that they remain functional. So if they're lying in bed all of the time, they get up out of bed, they move. If they're not going to work, the goal will be to get them back to work and back into life. And that's important to emphasize that those are some of the goals that you have for their care. So when we think about ruling out cardiac disease. In the past, we thought about, the standards: elevated troponin, elevated ST segment, abnormal echo. That's really your diagnostic tools for finding cardiac disease. And it had to be classic patients, older males with high cholesterol, high blood pressure, diabetes. But in the past 5 to 10 years, there have been some new studies showing that actually there is more microvascular ischemia than we expected. And the microvascular ischemia actually does have prognostic implications for patients, whereas before, microvascular ischemia was not thought to proceed down the coronary disease pathway. Now, this new diagnosis of MINOCA, M-I-N-O-C-A, or myocardial infarction with non-obstructive coronary arteries, it is now considered clinically significant. It's been increasingly recognized as a contributor to overall cardiac morbidity and mortality. It occurs more frequently in younger age women than typical MI. And this is a slide from an article and statement by the American Heart Association showing how this diagnosis is made. So in the patient who presents with an elevated troponin and an ischemic sign or symptom, and if they had non-obstructive coronary disease on angiography, then the working diagnosis would be either a missed obstruction, which can happen because some vessels are not seen on standard coronary imaging, or myocardial injury. And if that myocardial injury is occurring by non-classic ischemic mechanism, then that can be defined as MINOCA. So in this case, if you review the angiography findings and found obstructive coronary disease or dissection, that would be a definition of those disorders. If you found on the LV functional assessment that they had Takotsubo's, which is where the heart is stunned, or a cardiomyopathy, that rules out this MINOCA. And if the cardiac MR imaging showed a myocarditis or something else, a subtle diagnosis, then that would be helpful. Coronary vascular imaging can help identify plaque disruption, coronary emboli or thrombus or dissection, and coronary functional assessment is what's going to help you identify microvascular disease. And there's unclassified MINOCA and classified as microvascular disease. The important thing is medical management is the mainstay of treatment, identifying these patients. And I mentioned her history of preeclampsia. Preeclampsia and HELLP syndrome are known risk factors for development of cardiac disease later on in life, even in younger women who are atypical for developing coronary disease. So that is considered a cardiac risk factor, and that's also new within the last 10 years. So I think it's important to work collaboratively with your cardiologists to determine what patients may need to be reevaluated given these new criteria. Finally, so in summary, for those with chest pain, it's really important to exclude cardiac etiology, and especially with these new MINOCA criteria and the increasing recognition that women have atypical symptoms, it's important to work collaboratively with cardiology to risk assess and stratify patients. It may not be enough just to trust that they had an EKG in the ER. You're always listening, though, for exertional pain symptoms or typical chest pain symptoms and that elevated troponin to help guide who deserves that evaluation. For us as gastroenterologists and motility specialists, using manometry, pH testing, and endoscopy excludes diagnoses that are important and pathology that you need to find, and can help clinch that diagnosis of a functional disorder, which is a clinical diagnosis. Targeted neuromodular therapy has been shown to be effective in most patients, and cognitive behavioral therapy, which we'll hear more about soon, should be used together for symptom relief. Presenting it as a targeted approach to reduce sensitivity is different than just referring them for treatment of anxiety. And I often give a call to their therapist or to their prescribing provider and let them know what we're trying to treat because it's important that if they have an underlying depression or anxiety, that that gets managed, but that they also get focused therapy to help guide them to de-escalate their concern about their symptoms if we know that they're safe. And finally, PPI therapy should be optimized if there is any underlying GERD or NERD that is detected as present. But overall, the most important part of treating patients with functional disorders is that reassurance that you can give a patient if you create that patient-physician therapeutic relationship. And working together with patients over time, you can establish the comfort level that they need so that they understand that they're safe, that they have medications that can help them, and that over time, if they know what to look for, you'll make sure not to miss any significant findings that may develop in the future because they can partner with their care. And that's really important. Thank you for your time today, and I hope this case has been helpful.
Thank you, Ellen. And now it gives me great pleasure to introduce our final speaker for this session, David Katzka. He's a professor of medicine at Mayo. He's a master clinician, and he single-handedly has brought behavioral disorders, including belching disorders, into our vision and the management, actually, with diaphragmatic breathing. So, Dave, we're all excited to hear you.
Thank you, Prakash. You're too kind. And thanks, everyone, for having me here and for sticking around. I know it's so hard. It's late in the day. Thank you. All right. So I was asked to talk about behavioral conditions, particularly rumination and belching. And these are two very important disorders because, number one, as some of you may know by experience, and I've found this out too, if you wrap someone with rumination, it's not going to be good. And for the belching disorders, the same way, particularly if it's a primary belching disorder and they're swallowing a lot of air and now they can't get the air out of their stomach because they have a fundoplication there, we know that's also not going to be a happy patient too. So although they may see somewhat fringe, in fact, I think they're very central to what we do. So first we'll talk about rumination. Rumination has a strict criteria from the Rome Foundation, and it's symptom-based, and you can see that it includes persistent or recurrent regurgitation of recently ingested food into the mouth with subsequent spitting or remastication and swallowing, regurgitation but not preceded by retching, and then supportive criteria or regurgitation events usually are not preceded by nausea. In my experience, they're rarely preceded by nausea. Cessation of the process when the regurgitated material becomes acidic and regurgitant contains recognizable food with a pleasant taste. But I think the real task we have is differentiating rumination from other disorders which may be imitators, if you will. And indeed, still most of the patients I see with rumination come to me without a prior diagnosis, if you will, and more one of these two diagnoses. And we think about the differences of rumination versus vomiting and reflux. I think the presence of nausea is indicative much more of vomiting. I think, as I said, there's no retching with rumination. The vomiting often can occur much later after the meal, where rumination occurs almost during the meal or very quickly after the meal. And patients who vomit feel better after they vomit if it's an obstructive symptom. Their nausea gets better, whereas this doesn't happen with rumination. I think reflux is even a little bit more tricky, but the differences are that, again, there's no nausea, no retching, but I think most importantly is that if they're not on a PPI, there's acidic material, whereas in rumination, the food basically tastes the way it went down. I think reflux is going to occur during the entire day. It's not always so postprandial as it is with rumination, and particularly if it occurs at night when they're sleeping. Rumination does not occur at night. You can get isolated events. As far as weight loss, my experience, weight loss is not common rumination, but I think the key here is really the timing of when these regurgitation episodes occur. I think the other thing to think about is the physiology of regurgitation and reflux. And to basically have regurgitation, you have to have an absent lower esophageal sphincter, if you will. So these are patients who clearly have bad reflux, a large hiatal hernia, really no sphincter tone, reflux very much at night, as mentioned. It's not going to be your average mild reflux patient, if you will. I think this is one of the more difficult ones, and that's sometimes the telling the difference between rumination and achalasia. And I think the differences are that patients with achalasia tend to have a shorter history. They're not going to tolerate for this for very long, whereas patients with rumination can have this for decades. It's just the way they live. Weight loss is more common with achalasia. I think nighttime symptoms again. I think something else is foam. And I'm sure you all ask your achalasia patients about when food comes up, does foamy saliva come up as well? And just as they can't clear food, you can't clear saliva as well. So bringing up foam is really unique to achalasia and not to rumination, where the content comes up from the stomach. And another point I find, and curious if Prakash feels the same way, is when people with achalasia regurgitate, they give up. They said, that's it, I'm done. Whereas patients rumination, they just go along their merry way, ruminating, rechewing, swallowing, continuing throughout the meal. So I think giving up eating is more of a feature of achalasia. I think the one type of achalasia which is even more closely related, as Zubair nicely talked about this morning, is type 3. Because type 3, unlike the other achalasias, could go on for years. I don't understand that. Prakash told me years ago type 3 is a different disease. Now I'm really believing what he told me. So that could be a little difficult, but again, some of these symptoms will still help you differentiate type 3 from rumination. I think as far as the current diagnosis and management of rumination, it really comes back to the physiology. The idea that when gastric content comes into the stomach, a pressure builds up in the stomach that overcomes the LES pressure. You get flow of gastric content to the esophagus, the UES relaxes, and gastric content flows into the mouth. So it's really all about pressure gradient, if you will. And here's a characteristic manometric tracing of someone with rumination with the so-called R wave. So what you'll see here is if you look at the purple, which is the impedance, you'll see purple coming up into the blue past the lower esophageal sphincter. And if you see that sort of pinkish bar before the peristaltic contraction, that's the gastric strain or the R wave. The concept that patients with rumination somehow generate these very high gastric pressures. And again, going back to the physiology of the pressure gradient, it's really a matter of them generating pressures high enough in the stomach to overcome sphincter pressure and therefore cause retrograde flow. Now, one of the mysteries of rumination is how do they do it? It's purely subconscious. And I've had one patient, at least in my career, who could actually ruminate in front of me. But other than that, I've never been able to have a patient show me, and I challenge all of you to try to ruminate by increasing your abdominal pressure. There's something very unique about how patients accomplish this physiology on a subconscious level I just don't understand yet. Here's another example, and to sort of talk about one of the themes of this talk is that oftentimes, despite our ability to classify, there's a lot of overlap of some of these syndromes. So for example, here's supragastric belch-associated rumination. So you'll see the positive deflection in the proximal going to the distal lead of infinite impedance, suggesting there's a gas or an air in the esophagus. And after the swallow of air, then the event comes up. So whether this is the increased air distension of the stomach, which further increases gastric pressure and allows reflux or so-called rumination to occur, is something you have to think about as well. Now, we've heard a little bit about diaphragmatic breathing and how it can be useful for esophageal disorders. And one might assume that the reason diaphragmatic breathing works in rumination is because it helps these patients relax. But it really has nothing to do with relaxation. These patients are not more, in my experience, not more psychologically impaired than any other patient. They don't necessarily have high anxiety scores, though some may. So diaphragmatic breathing really works on the physiology of rumination, and I'll show you why. And in order to have diaphragmatic breathing work, you have to make sure patients are doing it the right way. They have to be able to make sure their abdomen expands and their chest stays stable. They have to do it for a long enough period of time. And part of this is either teaching it effectively in your office or trusting a good behavioral therapist or sometimes a pulmonary therapist to make sure patients learning it the right way. Because oftentimes patients say, I am doing the diaphragmatic breathing, I'll bring them into my office and I'll look at them, I'll say, you're not doing it the right way. We have to train them again. The other aspect is that just teaching them diaphragmatic breathing alone is not good enough. You have to teach them to do it when they eat and after they eat. And indeed, one of the most convincing ways to make this diagnosis is to have a patient come into your office with some food, have them eat, and teach them breathing. And all of a sudden, for the first time in 20 years, food is staying in their stomach and out of their esophagus. So you can't just use the the byline diaphragmatic breathing, you have to really make sure they're doing it and doing it the right way at the right time. And this is a brief schema of how they do it. You ask the patient to put their hand on their chest and one hand on their abdomen, and as opposed to regular breathing, and you can try this at home, it's safe. What you want to do is make sure when you breathe, you distend your abdomen and your chest stays still. That's diaphragmatic breathing. And by the way, this has become much more common therapy for a lot of disorders. Singers use it, martial arts, yoga, and patients with COPD use it, so they're less diaphragm dependent, is breathing. So there are a lot of disorders this is becoming useful for. So what about the physiology? How is it that diaphragmatic breathing works for rumination? Well, here's a study done by Magnus Halland at our institution in which we do continuous pH impedance monitoring with manometry on these patients with rumination, sometimes when we have to prove the diagnosis. So you'll see on the left a period of postprandial manometry in which you see the stars designating reflux or so-called rumination events, and then diaphragmatic breathing in the interim, followed by post-diaphragmatic breathing observation. And you'll see during diaphragmatic breathing that the rumination episodes go away, which completely return once they stop doing the diaphragmatic breathing. So what is the diaphragmatic breathing doing that's inhibiting these rumination episodes? And this just shows the proof of concept in this study, looking at the number of events of rumination before, after, during, and after, and you can see there are significant differences when patients do this. So how might the diaphragm help? Because after all, what we're doing when we breathe is we're changing the role of the diaphragm. The bulk of the main part of the diaphragm is relaxing and descending, whereas the crural diaphragm is contracting. The other thing we also know is that if we breathe through the diaphragm, we lower the intragastric pressure. Because after all, as opposed to regular breathing where the diaphragms go down, compartmentalize the abdomen, therefore increase the pressure in a smaller volume, by using diaphragmatic breathing, we reduce this gastric pressure. So as of course what you're thinking about now is we're changing that pressure gradient. So here, for example, are the pressures in the UES, the LES, and the intragastric pressure under conditions of baseline, rumination, no rumination, and diaphragmatic breathing. And you'll see at baseline, the UES pressure is high, LES pressure, and then intragastric pressure is low. When a patient has rumination events, the second bar over, you'll see that the LES pressure is now lower than the intragastric pressure, hence the reversal of flow. Patients oftentimes will have this reversal, but no rumination events. But once they do the diaphragmatic breathing in the far right, we reverse that gradient, and now the LES pressure is higher than the intragastric pressure, presumably because of increasing the crural contraction, and therefore increasing the external component of the lower esophageal sphincter. And here's the pressure gradient. Looking at those curves, you'll see baseline, rumination, no rumination, diaphragmatic breathing, and the other pressure gradient is high from stomach to esophagus in rumination, whereas it becomes negative in the other conditions. So this is why diaphragmatic breathing works, and part of this is also telling you relaxation therapy of other types, such as cognitive behavioral therapy, et cetera, unfortunately are unlikely to work for this syndrome. You really have to address the physiology. It's interesting, too, because thinking about the different role of the diaphragm in diaphragmatic breathing, there's a study looking at diaphragmatic breathing for these patients with idiopathic distension, if you will, and has very different activities on some of the abdominal muscles, such as the internal oblique, you'll see on the far right, as well as on the upper rectus. So whereas sometimes it's good for tightening muscles in the right places, it's good for lowering the pressures in other places. All right. The other therapy, and Phil talked about this a little bit, is the role of baclofen. And baclofen, presumably by increasing lower esophageal sphincter pressure by blocking TLESRs, has also been shown to work in rumination. This work from Natalie Ramel, Tim Van Eysel on TAC. Looking before and after baclofen, you'll see on the right that the number of rumination events is less with baclofen than it is with placebo. I tried the diaphragmatic breathing first just because there are really no side effects to it, although it is harder to learn. It's more time intensive and takes some time. If I'm going to give baclofen, it's tough for patients to tolerate it 3 times a day before meals. I don't know why it works this way, but sometimes giving it before bedtime helps it work during the day. I don't know how others you feel about that, if Prakash gives it that way as well. Okay, and this is just, oh, I'm sorry. Can I get this to go back? oh, there we go. This is just a figure from Jan's paper showing in the left before baclofen, on the right after baclofen, that bar outlining the increased pressure in the lower esophageal sphincter after the test meal. Okay, and this similar result as well. All right, now, one thing that's important is that oftentimes we make this diagnosis and we give ourselves a pat on the back. I made this diagnosis. They've been called reflux for 20 years. But I think we're in the next stage of this disorder, and that is figuring out why patients ruminate. And although we thought this, again, was a psychological issue, it's really not. And at least in my estimation, oftentimes this rumination is a protective response to some subliminal event. And so I think sometimes it's helpful to address the subliminal event. So some of these patients will have dyspepsia, and when they get dyspepsia, they start ruminating as part of a relief. If they have poor gastric accommodation with early satiation, this may be a way to relieve some of their symptoms as well, or delayed gastric emptying. Somehow they develop a fear of eating, and sometimes it starts with one static event 5 years ago, and sometimes they'll remember it. So I think trying to get to the underlying problem is helpful as well, in addition to the physiologic solutions we proposed. All right, now what about belching? Well, this nice article from Arjen Bredenoord's group, and Peter's done a lot of work on this, shows that the physiology of belching is air ingested. Ingested air accumulates in the proximal stomach, or there's some other gas, such as carbonated beverage. You get dilation of the fundus proximal stomach, which activates stretch receptors, the vagovagal reflex. You activate a TLESR, and you get rapid dilation of the esophagus, relaxation of the UES, and you belch. I'll have you note this is not too dissimilar from what we just described with rumination. It's less likely to happen to the supine position because now we don't have the fundus as the dependent structure, so air accumulates in the esophageal body superiorly, so it doesn't distend the fundus as much. All right, and the way we diagnose this now is with manometry. So just as this classic work from Don Castell, Ahmed Agrawal, and Amin showed that this is, of course, useful for measuring liquid events and has revolutionized our field. It's also important for differentiating the flow of gaseous or air events. So, for example, here we'll see on the left an air belch deriving from the stomach, or so-called gastric belch, from Andre and Arjen's article. And you could see the direction of flow is from distal to proximal, whereas on the right you could see it's a supragastric belch because the belch descends first proximal to distal and then is expelled distal to proximal. So that's the diagnosis for a supragastric belch. Sometimes it's tied to reflux. So here, for example, is a supragastric belch. You'll notice the subtle change from proximal to distal in terms of timing. And once it gets to the stomach and is expelled, you'll see a reflux event occurs with this. So sometimes it's difficult to tell which is the horse and which is the cart in patients who have belching and reflux. Whereas if the sphincter opens, it allows reflux to occur and air to come with it, whereas sometimes it's the initial air swallow that in turn allows the reflux to occur with it. And there you'll see. Well, this patient's a little more obvious. So here you'll see that this is a patient who's clearly injecting air through their upper esophageal sphincter on a constant basis. It's even too quick to swallow, if you will. And once you see this on a manometry, it's hard to forget, and you instantly recognize this is going to be one of your supragastric belchers. So the treatment is diaphragmatic breathing, but with one caveat, and that is they have to open their mouth. And the reason you open your mouth is because you can't swallow. You can't inject air into your past your UES. So for those of you who are not so sure, open your mouth and try to swallow, and you'll see it just can't happen. So patients will start with diaphragmatic breathing in the office with their mouth wide open, and with these patients who are these supragastric belchers who just belch in front of you for extended periods of time, like the ruminators, all of a sudden they stop belching for the first time in a very long time. Well, obviously patients can't walk around the rest of their life with their mouth open doing diaphragmatic breathing. So eventually they learn to keep their mouth slightly ajar, whether it's through practice with a pencil or something, so they block that swallow. And the diaphragmatic breathing helps because by spending more time breathing, they have less time to concentrate on swallowing. So diaphragmatic breathing with an open mouth technique can really change the life of these supragastric belchers. Now, with our classification, there are several ways with which we can tie together the rumination and the belching, so sometimes they're very related disorders. There's the primary rumination. There's secondary, again, which we swallow air, we reflux it, and then there's the supragastric. So sometimes we have to realize we're treating two different physiologies, not just one. So this is work led us to describe the use of diaphragmatic breathing in therapy for GERD, and it's also done by Magnus Howland at our institution. Now, why should we do this? Well, this is a paper from Dr. DeMeester from 1976, and I think about this paper a lot. It's like a great novel. You have to go back and read it over and over again. And what Tom did back in this time was to categorize refluxes into upright versus supine versus combined refluxers. And he showed elegantly back then the upright reflux really don't get esophageal damage, whereas, of course, the supine and combined refluxers are the ones who get the high-grade esophagitis, strictures, and Barrett's esophagus. He also showed at that time that upright refluxers, interestingly, have a lot of gas symptoms. So, for example, you'll see the prevalence of flatus and abdominal distension in the upright refluxers is very different than the supine and combined refluxers. So it makes you wonder what air or perhaps air swallowing has to do with upright reflux. So here's the demonstration that we've seen many times. Here's an upright refluxer, where you'll see why sleeping, there's no reflux, the quiescent period in the middle versus all these short-lived episodes before and after sleep compared to the supine refluxer, who does this. So two very different tracings and perhaps two very different physiologies. So we talked about pressure gradients before. This classic work from Melvin Sansom, looking at GERD patients and controls in terms of intragastric and intraesophageal pressures. And what you'll see is that in GERD patients in the dark bar, when these patients get to the TLESR, you'll see their intragastric pressure on the far right is greater than intraesophageal pressure. Just another way of showing that flow will return retrograde when you change the gradient. I'll remind you, this looks a lot like this. Here's our rumination syndrome. And so if we look at Jan Tak's data on baclofen, in fact, Jan was smart enough to measure not only rumination, but supragastric belching and reflux. And here you'll see with baclofen on the left compared to placebo on the right, there's a reduction in all of these, not just rumination. So it makes you wonder if upright reflux is in fact closely related to belching and rumination in a very different disorder. Hence our trial that Magnus conducted of diaphragmatic breathing on upright reflux. And think about it intuitively. How are you going to get flow to go from the stomach into the esophagus with an intact lower esophageal sphincter, which most of these upright refluxers have? You have to somehow increase your intragastric pressure, just like ruminators, to overcome that sphincter. And so what Magnus did is a study in which we did pH impedance tracing, and we randomized patients back and forth to diaphragmatic breathing versus not diaphragmatic breathing throughout the day. And so what Magnus showed is if you look at the sham versus the experimental, on the right, experimental diaphragmatic breathing on the left, you'll see there's a significant reduction in the percent time acid exposure in the diaphragmatic breathing group versus the sham group. So this, again, similar physiology, maybe a little bit different, where there's probably more effect on the sphincter pressure in the reflux patients, but no question diaphragmatic breathing, I think, works for some of the upright refluxers. And this has been shown not only by our group, but as early as 2012. Another group showed an uncontrolled trial doing this, a more recent trial. So there have been 3 trials, in fact, to my knowledge, showing that diaphragmatic breathing can be very effective for these upright refluxers with so-called normal physiology. So one thing I want to leave you with is that although we started off with what seemed like unusual disorders, or at least somewhat common disorders that are on the fringe of what we do, in fact, there's probably a close relation of many of these disorders, and hence the application of some of these new wave maneuvers, if you will, that really directly attack the physiology of all 3 of these. Thank you very much for your attention.
Thank you, Dave. That was phenomenal. Any questions for Dave? And let me start off by asking you, do you use buspirone for any of these patients with belching and rumination, and how does it work?
Thanks, Prakash. I think Certainly if I feel they have poor gastric accommodation, whether you do a water test or a SPECT scan, which I do in a lot of these people, and I think, by the way, that may be a part of the reason for refluxes as well, they have poor gastric accommodation. I will use buspirone. I found that to be very effective, thank you. Will I apply it as just a general remedy for dyspepsia for some of these patients? If I can't get them to respond to diaphragmatic breathing, then I will, yes. Thank you.
And what doses?
I start with 5 milligrams about half an hour before each meal TID, and then I may work it up to 10 milligrams depending on how they do. Do you do the same?
Yes, I find that they have a difficult time with the midday dose, so I might just use morning and evening, and 10 to 15 milligrams BID as the eventual target.
Yes.
To remind people, the anti-anxiety dose is a ceiling of 60 milligrams, so you're still quite low at that level. It's Walter.
Hi. Thank you. That was a great summary. You mentioned the abdominal distension and abdominal phrenic dyssynergia, and the paper showed that biofeedback therapy helped, although it's not really clear what type of biofeedback therapy would be specifically helpful in terms of what technique to do. And also, if you don't have a specific therapist that can do that type of biofeedback therapy, do you think diaphragmatic breathing might be helpful in that situation? I try that sometimes with my patients as well, because we're not able to do the same type of biofeedback. Or what other options would that be?
Yeah, it's a hard one, Walter. I do teach them diaphragmatic breathing as well, because you do get some tightening of some of the abdominal muscles, which I think helps prevent the distension. But you're right, unless you really do this the way the Spanish do or Gil Barucha does with EMG biofeedback on the abdomen, it's very hard to do it right. But in the absence of that, that's what I try. Thank you.
The point to remember is it's very easy, no side effects. Yeah. And you can initiate it at the office, and so if it doesn't work, there's no detriment, no loss to recommending diaphragmatic breathing.
Thank you.
And that's why we like the AJG article on diaphragmatic breathing in GERD so much in reflux disease, because it's a useful adjunct. So.
Thank you, Prakash.
Any other questions for Dr. Katska? If not, thank you very much for attending this advanced course. Thank you on behalf of the AFS. Thank you to all the speakers. I learned a lot. I hope you did too. And if you have any questions afterwards or any additional discussion, please use DocMatter and post your questions there, and we'll try to get the speakers to respond. Thank you very much.